Hi, good evening all, and welcome to just a minute. Hi, good evening all. Welcome to the last minute revision session of pharmacology. Just tell me whether the audio video is fine, and then we can commence this. Yes, or hi. Okay, just confirm the audio video is fine. Of pharmacology. Okay, so let us start with the session now. And so today's session is okay. Just confirm the audio video is fine. Some technical problem. So in this video, the main thing what we are going to discuss is the last revision of pharmacology, and it will be a complete revision of pharmacology. So I'll try to cover maximum in this discussion. So I think audio video is fine, and or if you can make a notes, you can make it. Otherwise, don't worry. At the end of this video, I'll be sharing the PDF with you. And to get the PDF, you have the Telegram group of me where you can approach there. I can share. Okay. Let us start without wasting our time from here. So my first thing is think big, trust yourself, and make it happen. So I understand that at this point of time, you are stressed up. There are 19 subjects to be studied and so many things to be remembered, and the lack of confidence is more now. So my request is tell your brain that you are prepared really well, and tell your brain that you are going to excel in the exam. So please understand, everybody are going through the same phases, and confidence is the key at this point of time. Now let us discuss the pharmacology. I think it will go for another 3-4 hours because I got to cover majority of the topics right now. Let us start with the first topic, that is respiratory pharma, and we are planning in a sequential manner or a topic wise manner. First is respiratory, then GIT, then ENS, general pharma. So most of the pharma will be covered, so don't worry, and keep answering, keep interacting. That's it, I want you. And don't, if you can't write, don't worry, I will share the PDF. Please answer, please try to answer more and more. So that's what I told you. No need to make notes, just listen, and I will share the PDF at the end. Okay, so it's up to you. If you let's start now. Now, first question is, which one of the following is a phosphodiesterase inhibitor used in bronchial asthma? So in pharma, most of the questions are mechanisms. So the first question is, which is a phosphodiesterase inhibitor? The answer for this is option B. The answer is aminophylline. So please understand, any drug ending with phylline, they are methylxanthines, they are bronchodilator, and they inhibit the enzyme phosphodiesterase. Now the names formoterol, salmeterol, they belong to long-acting beta-2 agonist. They are LABA drugs. Magnesium sulfate is also a bronchodilator. And ipratropium bromide is a muscarinic antagonist. We call it as SAMA. That is short-acting muscarinic antagonist. And the drug LAMA, the name is called tiotropium bromide. Tiotropium bromide. So please understand, all the options here we have are bronchodilators, And the phosphodiesterase inhibitor is aminophylline, and you can remember one more drug, the name is theophylline. The next question is methylxanthines adverse effect. Now they can cause seizures, they can cause diuresis, they can cause arrhythmia, they can cause headache, nausea, vomiting, gastric discomfort. How do I remember this? Simple. Methylxanthines are nothing but the coffee, tea, what we drink. Now what happens if you drink more coffee? CNS gets stimulated, so seizures. What happens if you drink so much of tea? Urine will be more and heart rate will be more, arrhythmia. So you will have headache, nausea, vomiting, gastritis and all those things. But the question is, what mechanism is going to cause seizures and diuresis? It is due to adenosine blockade. It is due to adenosine blockade. And headache, nausea, vomiting and gastric discomfort is due to blockade of phosphodiesterase 4. And CVS, arrhythmia, is due to both adenosine blockade and phosphodiesterase 4 blockade. So please understand, these are the methylxanthines adverse effect. Seizures and diuresis are due to adenosine blockade by methylxanthines, and headache, nausea and gastric discomfort is due to phosphodiesterase 4 inhibition. And arrhythmia is due to blockade of both. So that's why we made a table, and keep this in your mind, you will never forget. Brain, then kidney, adenosine, and others phosphodiesterase 4, and arrhythmia both. That's it. That's it. Now moving on to the next drugs in asthma, the drugs used as controllers or prophylaxis in asthma. Now in the prophylaxis, they ask you the mechanisms. The first drug is montelukast. Can you tell me what is the mechanism of montelukast? It's a leukotriene receptor antagonist. Now any drug having nidochromyl and sodium chromoglycate, they belong to mast cell stabilizers. They are mast cell stabilizers. And please tell me xylitol, what is the mechanism of xylitol? Yes, Dr. Bharat, the arrhythmia is due to phosphodiesterase 3 inhibition in the heart, correct. Now xylitol is an inhibitor of the enzyme LOX lipooxygenase. Now the name omalizumab is IgE blocker. It's a IgE blocker. And these are new drugs for asthma. The name is called reslizumab, benralizumab, mepolizumab. If you can, you remember. Otherwise, no need to worry. They are for INACT. But what do they inhibit? They inhibit mainly interleukin 5 blockers. And they are preferred when there is severe eosinophilic asthma. Otherwise, most commonly asked question in your exam is the mechanism of montelukast, which is a leukotriene receptor antagonist. And most of the examiner will test whether you use these drugs in attack of asthma. No. What is the question that is repeated? Whether you use these drugs in acute attack of asthma? No, because they are not bronchodilators. They are just controllers of asthma. So these are the points you have to keep in mind in asthma. Mechanisms I have told you. Now the next thing what we need to understand is true or false. Now that's why I told you these sessions should be interacting, because you already studied. Let us check that. Salbutamol causes tremors, tachycardia, tolerance, hypokalemia, hyperglycemia. Is it true or false? Is it true or false? Yes, it's a true statement. So salbutamol can cause tremors, tachycardia and tolerance. Not only that, it can cause hypokalemia and hyperglycemia. But the confusion what we get in the exam is whether it is hypo or hyper. Remember the alphabet A, B, C, D, E, F, G first and then comes K. So salbutamol increases glucose, number 1, decreases potassium because G comes first in alphabet, then comes K. So this is a true statement. The next question in the asthma is most common adverse effect of inhaled corticosteroid. So when we inhale the corticosteroid, the most common adverse effect is oropharyngeal candidiasis. And what is the method to prevent this is simple mouthwash or gargling. But how do you treat this? Tell me, how do we treat this candidiasis? It's a true statement also. fluconazole is given orally, and that is the second choice. So always give topical. If not responding, then go for fluconazole. Or sometimes we also give nystatin, but nowadays what is preferred is clotrimazole, which is available. And if it is not there, you can give nystatin also. Right? So that is about the drugs for asthma in brief. Now, another thing they will ask you in the exam is asthma, which drugs you should not give. This has been repeated plenty of times. Please listen to this. Now, suppose a patient is having bronchial asthma, which drug you should never give? That is contraindication. We should never give morphine because morphine is a bronchoconstrictor because it releases histamine. Cholinergic drug can because of the risk of bronchoconstriction. So please understand morphine, cholinergic drugs, histamine, adenosine, carbaprost, propranolol and timolol are not given in a patient with bronchial asthma. Very, very important. Okay, now I think the stream is coming fine. If it is stuck, I will tell you again. Bharat, we will give clotrimazole. If it is not responding, then we give fluconazole. That is the second choice we can tell. Okay, now that stream is fine. These are the asthma drugs. You should not give it in asthma patient. Right? These drugs should never give in asthma patients. Sir, how do I remember this? Now for that I have put some asthma condition and I have asked you to choose this. Now first of all, a pregnant woman has come with hypertension plus asthma. Will you choose labetalol or will you choose nifedipine? Answer me. Please interact. Yes, tell me. If a patient has come, pregnant woman has hypertension, asthma, will you give labetalol or nifedipine? Please answer this. Now, labetalol is the drug of choice for pregnancy in hypertension, but she is having asthma and labetalol cannot be used. So what is preferred is nifedipine. Krishna, that's what. Labetalol is the drug of choice, but here I cannot give because labetalol can cause bronchoconstriction. Mr. R, read the question carefully. That is why I am telling you, if the patient is having asthma, you should be careful in reading the question. Second question is, suppose a patient is having atrial fibrillation and asthma, will you give beta blocker or will you give verapamil? I will prefer giving verapamil or his friend diltiazem because these are not going to cause bronchoconstriction. Again, third, suppose a lady okay guys, so I think now it is fine. Sorry, I had to do it from my home. That's why some issues here, but let's not stop the learning. Now, pregnant woman with hypertension and asthma, I told you. Okay, so the next question is number 5. Patient is having PSVT and asthma. Will you give adenosine or will you give verapamil is the question. So I will give verapamil because adenosine is a bronchoconstrictor. Now you check any exam question, a patient with asthma and which drug is contraindicated is always asked. Always asked. Let me repeat again. Pregnant women having hypertension and asthma, labetalol should not be used because of asthma. Atrial fibrillation with asthma, we don't give beta blocker, we prefer CCBs. Postpartum hemorrhage with asthma, we prefer oxytocin. Carbaprost is a bronchoconstrictor, we don't give it. Glaucoma plus asthma, we prefer bitoxolol because it is cardioselective. Timolol, we don't give it. PSVT with asthma, we prefer CCB like verapamil. Adenosine, we don't use it because it's a bronchoconstrictor. So tell me whether you got these points because drug and bronchial asthma is repeatedly asked in the exam. So that's why we made this table, and you check any exam, they will ask you in asthma patient, can we give this drug or not? Right? Yes. Now let me move on to the next one, the GIT pharma. Let us move on to GIT pharma. I'm sorry for interrupting in between the stuck and all because of the issues with the internet. Let's start learning. Now, which of the following drug used in peptic ulcer disease is an anticholinergic drug? Now, all the options mentioned here are all drugs for peptic ulcer disease, but which one is anticholinergic? The first one is anticholinergic. The name is called pyranzipine. So, pyranzipine is an anticholinergic used to manage. It's used to manage peptic ulcer disease, asked in NEET 2018. Pantoprazole is a proton pump inhibitor. It inhibits a pump called H plus K plus ATPase pump. Sir, is it reversible inhibitor or irreversible? Remember, the inhibition is irreversible. The inhibition is irreversible. Misoprostol is a prostaglandin that is also used in the management of peptic ulcer disease, and ranitidine is a H2 blocker. So when I am telling you this H plus K plus ATPase, can you tell me a drug which blocks sodium potassium ATPase pump? So can you tell me one drug which blocks sodium potassium ATPase pump? Please answer that. It's a CVS drug. Please answer it. CVS drug, and the CVS drug name start with D. The name is called digoxin. So this is called comparative study. When you know this, you should also compare with the sodium potassium ATPase. And in all this, the most efficacious drug is pantoprazole, that is PPIs are most efficacious. Now let us move on to the next one. Among the drugs in peptic ulcer disease, what is the fastest acting drugs in peptic ulcer disease? Can you answer that? Drug of choice for NSAID induced peptic ulcer disease is proton pump inhibitors, that is PPI. Most specific drug for NSAID induced peptic ulcer disease. What is the most specific drug? The name is called misoprostol. So please read the question carefully. Drug of choice if they ask you PPI, specific drug if they ask you, the answer becomes misoprostol. Misoprostol not used in pregnant women with peptic ulcer disease. Is it true or false? Tell me. Is it true or false? False. Because I cannot give misoprostol in pregnant women because it will cause abortion. She came with peptic ulcer disease and you aborted her. We don't want that. The fastest acting drugs in peptic ulcer disease, nobody answered this, guys. The fastest acting are antacids. So they act quickly in peptic ulcer disease. They neutralize the acid quickly. So these are the questions which will come from the peptic ulcer disease. Now in peptic ulcer disease, another thing is H. pylori eradication. Now we can use 3-drug combination, that is clarithromycin, amoxicillin with PPI, clarithromycin, metronidazole. Tell me guys, how many days the duration should be? Last question should be true now. No, misoprostol not used in pregnant with peptic ulcer disease. Yes, it's a true statement. Correct. It's a true statement because we don't use it. Now tell me, how many days should I use H. pylori eradication regimen? Yes, most of you have answered. It is 14 days. Now there is a regimen called quadruple drug regimen. It contains PPI, bismuth, tetracycline, metronidazole. That is also given for 14 days. So these are the drugs for the H. pylori eradication. PPI, antibiotics like clarithromycin, amoxicillin, metronidazole, tetracycline and bismuth are used to eradicate H. pylori. Now moving on to the next one, case-based. So let us analyze the case-based. A pregnant lady has come with nausea, vomiting in first trimester. What is the drug used? Tell me, what is the condition called as? The condition is called as morning sickness. So what is the drug of choice for morning sickness? So please try to answer more and more, because at the end of the video I will be sharing the PPT for you. So please try to answer this. So the treatment will be doxylamine with B6. That is the drug of choice. Dr. Bharat, quadruple is used when triple therapy doesn't work out. So obviously it will be superior. Planning to go with friends to ascend rapidly to Ladakh for jolly. What is the drug used for prophylaxis? So you want to go to Leh Ladakh, very high areas, and you have to take a drug prophylactically. What is the drug name? And why are you taking it? So when I go to high altitude, I can develop high altitude sickness, also called as acute mountain sickness. So the prophylaxis is acetazolamide. So acetazolamide is used for prophylaxis also. It is used for treatment of acute mountain sickness. Yes, very good. Now the third case is planning a trip to hilly area with curvy road. So you are going a curvy road and previous history of vomiting in the trips. What is the drug for prophylaxis? Now what is this? This is called motion sickness. So what is the treatment for motion sickness? The first choice is hyoscine. If that is not given in the option, then I can go for a drug by the name promethazine. So it's a case of motion sickness. Now coming to another thing, metoclopramide was given. Remember, metoclopramide is an antiemetic. It blocks dopamine receptor. The patient developed torticollis and upward rolling of eyeball, and that is called dystonia. What is the treatment for this? So I am waiting for your answer. I am waiting for your answer. Yes, hyoscine and scopolamine are same drugs. Now this is a case of acute dystonia due to metoclopramide. The treatment is mainly benzhexol. If benzhexol is not given, we can give a drug by the name promethazine. We can give promethazine. So these are the options. Now a patient came with high gastrin levels and acidity. So high gastrin levels and acidity classically seen in a syndrome called Zollinger-Ellison syndrome. So Zollinger-Ellison syndrome, what is the drug of choice? The drug of choice is PPI, that is proton pump inhibitors can be used. Okay. Remember, benzoxol has been asked plenty of times in the exam. If that is not there in the option, go for promethazine. Okay, go for that. So please understand, these cases have been tested plenty of time. Morning sickness, motion sickness, altitude sickness, then metoclopramide, the dystonia and treatment for that, and Zollinger-Ellison syndrome. Let us move on to the next one. Suppose a patient has anorexia and HIV patient, which antiemetic is used? Now remember, the antiemetic that is used in anorexia also is, the name has NABI in the name. The name is NABI. If it is alone, nabilone. One more name is dronabinol. So it has NABI in the name. These are cannabinoid 1 receptor agonist. Now what laxative used in hepatic encephalopathy? The name is called lactulose. So lactulose is used in hepatic encephalopathy. Can you tell me the purgative causing melanosis coli, that is pigmentation of colon? And anybody tell me which drug can cause melanosis coli? You know henna, the name also sounds like that. Henna, similar sounding drug is senna, very good. So senna can cause melanosis coli, that is pigmentation of colon. Yes, that is about the GIT pharma. This much information is enough. And let us move on to the exciting topic, that is ANS pharma. ANS pharma. Autonomic nervous system, the most important drug they will test you in the exam is adrenaline. So match the following with the concentration. So we have given one side the dilution, that is A, B, C, match it. Yes, nabinon is a cannabinoid 1 receptor agonist. 1 in 1000, remember, is given whenever we give IM. So IM route we use 1 in 1000. That is, this is A for A. Now 1 in 10,000 is given whenever we give the drug IV, that is in cardiac arrest. 1 in 50,000 to 2 lakh is given with local anesthesia, that is lignocaine. I hope all of you agree for this. But every time the adrenaline keeps on coming in the exam, remember this table is useful. 1 in 1000 we use it when we are giving IM, subcutaneous, or by using nebulization. So which one I should remember? Most of your exam will test anaphylactic shock. The drug of choice is adrenaline because adrenaline is a physiological antagonist of histamine. So it is given in anaphylactic shock or angioedema. The dose is 0.3 to 0.5 milligram or ml, and the dilution is 1 in 1000. It is given IM, particularly the vastus lateralis. So if you want to give IV, IO or endotracheal, the dilution is 1 in 10,000. And if you give it lignocaine, it is 1 in 50,000 to 1 in 2 lakh. Right? This much information is enough. So dosing and all, NEETPG, they usually don't ask, so don't worry with that. They will ask for dilutions mainly. The doses will be for ionicity pattern of exams. Okay? Yes. Now coming to the which of the following statement is false? When we give noradrenaline, there is increase in systolic BP, diastolic BP, mean artery pressure, reflex bradycardia. Is it true? Yes. Remember, noradrenaline never decreases any BP. Followed by reflex bradycardia. That is what happens when we give noradrenaline. And whenever we give noradrenaline, we check the mean artery pressure. If it is rising, then the drug is working. Dopamine at very low dose increases urine output. Yes, that is also true statement. So dopamine, when we give it at the dose of 1 to 2 microgram per kg per minute, it causes renal vasodilation and that increases urine. Dobutamine, yes, it is used in cardiac stress testing, true statement. And phenoldopamin is a D1 agonist used in hypotension management. This is false. This is false because it is used in hypertension emergency, not for hypotension. So the answer will be D. The false statement is D. So what did I study from this MCQ? I studied what is the action of noradrenaline. I studied what is dopamine action at low dose, dobutamine, and where do I use phenoldopamin, and the mechanism we understood from this. Now another question is, they will ask you what are the drugs for shock. Remember, whether it is septic shock, neurogenic shock, hypovolemic shock, hypotensive shock, for all these shock, the drug of choice will be noradrenaline. So the vasopressor of choice is noradrenaline for everywhere. Septic shock, we give antibiotic. Hypovolemic shock, we give IV fluid. And the best drug in all these cases is noradrenaline. Noradrenaline is also one of the best for cardiogenic shock. Cardiogenic shock. So if they are given cardiogenic shock and you want to choose, it is noradrenaline. Suppose there is cardiogenic shock plus oliguria. If the urine has come down, then the drug of choice will become dopamine. Then becomes dopamine. This much information should be remembered. But please remember, for anaphylactic shock, the drug of choice is adrenaline. Noradrenaline will never be useful in anaphylactic shock. You can give it in any shock, but not in anaphylactic shock. So please keep these things in your mind. Now, hypotension. So patient may come with emergency hypotension. So any hypertension which is severe, I can give noradrenaline. So noradrenaline can be given. The other options are phenylephrine. And one more drug what we use is ephedrine. So these are the emergency drugs used in severe hypertension. Orthostatic hypertension. Can you tell me, orthostatic hypertension, what is the commonly used drug? Postspinal hypertension, what is preferred is phenylephrine again. Phenylephrine is again preferred more than ephedrine. So tell me what is used in orthostatic hypertension. Mr. R, anaphylactic shock, there is bronchospasm. It is reversed by adrenaline by acting on beta 2, and noradrenaline will not act on beta 2. So it is not going to cause bronchodilation like adrenaline. So orthostatic hypotension is not an emergency. So we use a drug. The name is called midodrine. midodrine. Yes, nobody answered that. Midodrine and a drug called droxidopa. I think you have heard of levodopa. The name is droxidopa and midodrine. So please understand the name midodrine. At least remember these drug. The name is midodrine. So remember, when I get up, I will be down. Me down. The name is midodrine. So this one I want you all to remember mainly. Okay, sir. Now dopamine. Don't confuse dopamine with dobutamine. Dopamine is coming everywhere. That means it is everywhere. That means it acts on every receptor. So it can act on D1, beta 1 mainly, and alpha. Suppose you get low dose, it can cause renal vasodilation. Medium dose, it can increase cardiac output. High dose, it can cause vasoconstriction and increase the BP. So this is the various dose of dopamine what we use, but don't confuse with the drug dobutamine. Please remember, dobutamine is entirely a different drug. Remember, but it doesn't work on dopamine. No action on D1 or D2. Its main action is on beta 1. And most of them confuse dopamine and dobutamine. Yes, midodrine is an alpha 1 agonist. It's a prodrug and it can activate alpha 1. Very good. Yes, next important questions they will ask you is name some alpha 2 agonist. This mechanism has been tested plenty of time. Can you tell me an alpha 2 agonist used for ICU sedation and used as pre-anesthetic medication? I will give a clue. The name start with DEX. Because in the exam, questions are already there. Answers are also already there. Only you have to choose the right one. That's it. Yes, it's there in the description, Shivaji. Now tell me the name. Alpha 2 agonist used in hypertension. The name is clonidine and a drug called methyl dopa. Yes, tested plenty of time. Yes, Kavi, you are right. It is called dexmedetomidine. So alpha 2 agonist is a favorite for examiner. That is separate table. Alpha 2 agonist used as central skeletal muscle relaxant. The name start with T. Tizanidine. Alpha 2 agonist used. I think you will tell you that. You will tell that. Alpha 2 agonist is used in glaucoma. Alpha 2 agonist used in opioid withdrawal management. The name start with L. Lofexidine is used. Not only lofexidine, even clonidine is used for opioid withdrawal symptom. Yes, guys. Baclofen Kavi is a GABA B agonist. It has nothing to do with alpha 2. That is why the examiner tests this table. The names also end with lidine. The name is apraclonidine. And one more name is brimonidine. Brimonidine. So please go through this alpha 2 agonist chart. Please go through this. Okay, so that's what Soumya, you may forget. Let's revise that. That's the purpose of this today's video. So we are done with alpha 2 agonist. Now let us come back to another question. A patient with diabetes and COPD. COPD means asthma, COPD, they are respiratory disease only. Developed post-operative urine retention. Which of the following drugs can be used for short-term treatment to relieve the symptom of this patient? So can you choose this? Patient is asthmatic now. Patient is having COPD, diabetes, and after the OT he developed urine retention. What drug can be used? Can you tell me? Waiting for your answers, guys. What drug can be used? Now I know, sir, bethanocol can be used, sir. But remember, col, if the drug ends with col, is a cholinergic drug, and cholinergic drug causes bronchoconstriction. Already patient is having COPD, I cannot use it. So what is remaining is tamsulosin. I know tamsulosin is used in BPH, but tamsulosin is also preferred. Suppose the patient has post-operative urine retention, for brief period we can use that. And these are the answers. Remember, That is why I told you, when you read this type of questions, always check whether there is asthma COPD in the question. That means it's a trap for you. Okay, that's a trap for you. And most of you answered bethanocol. Please don't do that. Now, again, bladder conditions, we have made a table. Overactive bladder. Where do you see that, sir? UTI. Post-operative urinary retention after surgery and stress urinary incontinence. Now, overactive bladder, you have to remember one important drug, mirabegron. Mirabegron is a beta-3 agonist. So that will be asked in the exam. Then oxybutynin. Then there are two phenacin, solifenacin, darifenacin. These are for overactive bladder. Post-operative urinary retention, the name is bethanocol. But in this case, we didn't use bethanocol because bethanocol can cause bronchoconstriction. Tell me, stress urinary incontinence, we do surgery. Stress urinary incontinence, we cough, the abdominal pressure increases, urine will come out. But the best thing is surgery. But until surgery, I have to do something. So what should I use in this patient if he has stress urinary incontinence? Tell me, guys. The name starts with D. The name is called duloxetine. And duloxetine is an antidepressant belonging to SNRI. SNRI. And don't confuse this drug with duloxetine. Duloxetine belongs to SSRI. And duloxetine is used in a sexual problem. Anybody? Duloxetine is used in a sexual problem. What is a sexual problem? We use duloxetine. Please try to answer, guys. Whether you are right or wrong, that is secondary. Okay, so please tell me, duloxetine is used in a sexual problem that is called premature ejaculation. Duloxetine is used in premature. Yes, you are right. And don't confuse duloxetine, which is SNRI, because these are the mistakes what we do in the exams. We study from some books, we study from various classes, but at the end of the day, the mind will confuse this concept. That's why revisions are important. Now coming back to another question, 48-year-old patient was having abdominal colic due to acute gastroenteritis. Which of the following is mainly used to relieve colicky pain? So patient is having colicky pain, then what drug should we use? Pyrazipine is mainly used for peptic ulcer disease. Glycopyrrolate is a pre-anesthetic medication. That means we use it before anesthesia to decrease the secretions and to decrease reflex vagal bradycardia. So the drug that is used is dicyclomine. And ipratropium bromide is used in asthma. Just now we discussed that. So the answer will be dicyclomine. And dicyclomine is also used in a painful menstruation that is called dysmenorrhea. Dysmenorrhea. Very good. Most of you answered that. Very good. Very good. The answer is dicyclomine. Yes, DB, Dr. Bharat, KK, Soumya. Very good. Very good. Now, another toxin they will ask you in the exam, twice repeated, mechanism of action of botulinum toxin. So please answer this. I'm waiting for your answers. Mechanism of action of botulinum toxin. A, B, C, D. A, B, C, D. Can you answer this? Binds NM receptor and prevent activation. See, the NM receptor are present in neuromuscular junction, and the drug which blocks NM receptor, they belong to D-tubercularine, or they end with curium, like atracurium, cisatracurium, or they end with curonium. They are peripherally acting skeletal muscle relaxant. Binds muscarinic receptor and prevent activation. They are nothing but anti-muscarinic drug like atropine. They are anti-muscarinic like atropine. Blocks uptake of choline into terminals of the nerve. They are hemicholinum, not so important. So the answer will be prevent release of acetylcholine from presynaptic terminal. The answer is D. Yes, it's a snare blocker. Very good. And botulinum toxin is a variant we use, Ona botulinum toxin A, that is used for one condition. I will tell you, overactive bladder. One more condition is migraine prophylaxis. As such, Botox is used for the cosmetic purpose. That's it. So answer is D here. The answer is D here. Now moving on to the next condition they will ask you is Myasthenia gravis, a problem of neuromuscular junction. What is the drug used to diagnose myasthenia gravis and to differentiate myasthenia and cholinergic crisis? The name starts with E. Tell me the name. What is the anticholinergic drug used to treat myasthenia gravis? The names are neostigmine and pyridostigmine. So these are the anticholinergic drug used for myasthenia gravis. So the name is edrophonium, which is used to diagnose myasthenia gravis, and the test is called tensilon test. The test name is tensilon test. Are amyloglucoside or tetracycline avoided in this patient? Yes, amyloglucoside and tetracycline, they themselves cause neuromuscular blockade. Already there is muscle weakness in myasthenia gravis. Should I give amyloglucoside and tetracycline? No, don't give it. Right? So this is about myasthenia gravis. Coming to another disease, Alzheimer's disease. Remember, there is decrease in a neurotransmitter called acetylcholine, and the drugs which we use are guard memory when you are aged. What is guard for? GA stands for galantamine. D stands for donepezil. Our second question also, the drug used is edrophonium. And what is R for anybody? These are the anticholinesterase drugs. They increase acetylcholine. Then we have M for memory, that is memantine. Memantine is an NMDA blocker. Memantine is an NMDA blocker. Yes, these are new drugs, aducanumab, lecanemab. So aducanumab and lecanemab are new drugs for Alzheimer's disease. They block beta amyloid plaques. The target is beta amyloid plaques. So R stands for rivastigmine. Rivastigmine. And please remember, both rivastigmine and donepezil are also available as patches. You can apply them as patch. That is also been tested. And one old drug called tacrin is not used nowadays because tacrin was toxic to the liver, hepatotoxicity. That's why we don't use it. So that is about drugs for Alzheimer's disease. Now coming to the next one, poisonings. Poisonings, it can be a pharma question, medicine question, or forensic question. Now, whenever there is poison, always check the pupil. There are two conditions where there is meiosis. Drug addict with pinpoint pupil, respiratory depression, and hypotension, hyperreflexia, and hypothermia. Now, tell me what is the drug of choice for first case. Tell me what is the drug of choice for second case. Kavi, if you ask the drug of choice for Alzheimer's disease, I will go for donepezil. Usually they don't ask. If they ask, that is the answer. Yes, it's a opioid poisoning like morphine. And what is the antidote for opioid poisoning? The antidote name is naloxone. Sir, why naloxone? Because you can give it IV. IV drugs will act immediately. Now, obviously, when a farmer has meiosis, increased secretion, salivation, lacrimation, urination, low RBC esterase, what is the drug of choice? What is this poison? It is a OP or carbamate poisoning. Now the drug of choice is atropine. So the drug of choice is atropine. Sir, how do I know which one is what? Both will have meiosis. Remember, if there is respiratory depression, hypotension, hyperreflex, hypothermia, it is opioid. And pinpoint people are meiosis with cholinergic excess, salivation, lacrimation, urination, that is OP or carbamate poisonings. Yes. So by the pupil only you can diagnose what poison you are dealing with. Yes, Ashish, naltrexone is an oral drug. Now moving on to the next condition where pupils are dilated. Now let us read this question. Drug addict, he has a dilated pupil, he is agitating, sweating a lot, he has tactile hallucinations, nasal perforation, high BP and heart rate. What is the suspected drug? Anybody? I'll come to that, Crystal Medicos. What is the suspected drug here? Now please understand, BP is high, heart rate is high, we can suspect sympathetic drug, and the indirectly acting sympathetic drug is cocaine. Remember, cocaine is not a direct sympathetic, it's an indirect sympathetic. It can cause tactile hallucination, nasal perforation. The suspect drug is cocaine. Now, child ate berries, blurring of vision, dilated pupil, confusion, flushing, tachycardia, and high temperature. What is the suspected drug? Anybody? Second drug? Ashish, heroin will not do this dilated pupil. Heroin is nothing but morphine-like. So morphine-like will cause meiosis, not dilated pupil. So heroin cannot be the answer here. There is no drug of choice for cocaine poisoning. We have to manage symptomatically. Check the BP, lower the BP like that. Yes, it's a case of atropine poisoning, atropine or datura poisoning, or atropa belladonna poisoning. What's the drug of choice for this atropa poisoning? The name is physostigmine. The name is physostigmine. Sir, why physostigmine? Because physostigmine can cross blood-brain barrier. Don't confuse this with pyridostigmine. Remember, physiology crosses the blood-brain barrier. Right? So it's a case of atropine poisoning. Sir, how do I know whether it is cocaine or atropine? Remember, sweating, if it is present, it is sympathetic overactivity. Now, atropine is an anticholinergic. So remember, there is no sweating in case of atropine poisoning. Sir, why there is no sweating in case of atropine poisoning? Because it blocks M3 receptor. Now, what is the role of M3 receptor? They are mainly required for thermoregulatory sweat glands. Why do we require sweating? To lose the temperature. Now, if you block the sweat gland, the temperature is not lost. So you don't see sweating. What you see is high temperature, and how to lose the temperature? By vasodilation, that is flushing. So please remember, sweating means sympathetic. No sweating means atropine-like drug. Somebody had asked me, sir, OP poisoning, the drug of choice is atropine. Carbamide poisoning also atropine. Where I can add oximes. You can add oximes in OP poisoning. Oximes are absolutely contraindicated in carbamide poisoning. Oximes are absolutely contraindicated in carbamide poisoning. So guys, this is how I can identify by checking the pupil which poison and what is the drug of choice. The next thing what we are going to understand here is the antidote. Now, there is no exam without an antidote question. So let us see that organophosphate and carbamide poisoning, we have discussed the drug of choice is atropine. Atropine, belladonna, datura, the name is same. The drug of choice is physostigmine. So please please note down this. Please try to answer. Digoxin, anybody? Cyanide, I want you to answer this. Benzodiazepine, Z drugs, and beta carbolin. We use a drug called flumazenil. So when you get a flu, mazenil ho jata hai. That is for benzodiazepines like diazepam, lorazepam. Cobra bite, it's nothing but anti-snake venom. Anti-snake venom. Please remember, along with that, we add neostigmine, pyridostigmine to overcome muscle weakness. Digoxin, the antidote name is digibind. Most of you are correct. What is the other name for digibind? It is also called as digifab. Cyanide toxicity, what we use is hydroxycobalamin. Hydroxycobalamin, because it will become cyanocobalamin and go out. We can also use a combination of amyl nitrate and sodium thiosulfate. Right. Yes. Neostigmine is used in cobra bite, that is cobra. Because cobra toxin is neuromuscular toxin. and there is muscle weakness. To overcome muscle weakness, we add neostigmine or predostigmine. Now, why do we add atropine along with that neostigmine, predostigmine? To stop the muscarinic adverse effect. To stop the muscarinic adverse effect. Okay. Yes. Sir, OP antidote is pyridoxine. No, Reno. OP antidote, organophosphate antidote is atropine. We have discussed that. Now coming to beta blocker, metoprolol is a beta blocker. What is the antidote? Anybody? I am waiting for your answer. Valproate hyperammonemia, the name is carnitine. Ethylene glycol and methanol, the name is fomepizole. Opioid we have discussed just now, naloxone. It's a revision, just listen. You already have studied, just listen. CCB, calcium channel blocker, toxicity, we use calcium gluconate. Yes, metoprolol, we use glucagon. And TCA, tricyclic antidepressant overdose, lignocaine overdose, these two are for you guys. Tell me the answer for these two. Tell me the answer for the last two. Yes, R, you are right. TCA overdose, the name is sodium bicarbonate. We use that. That has been tested. Lignocaine overdose or local anesthesia overdose, 20% intralipid. 20% intralipid is given. Very good, R. So, please note down these antidotes. Frequently tested. The next question is, a 45-year-old man had performance anxiety and migraine headache. Obviously, when there is performance anxiety, migraine also, we use beta blocker called propranolol. What comorbid condition listed below you should be very cautious while using propranolol in this patient? Is it essential tremor, akathisia, hypertension, or bronchial asthma? Please tell me the answer. Simple answer is, where you should not give propranolol, which condition is the simple understanding of this. Now, please understand, any drug ending with lol is a beta blocker. Any drug. And propranolol is a non-selective beta blocker. That means it blocks both beta 1 and beta 2. And they should not be used in asthma patient. Yes, most of you have answered it correct. The option D is bronchial asthma. Now moving on to the next one, beta blocker. What should I remember for the exam, sir? Now let me simplify the things, because most of the times what happens, we skip pharma and try to go to the exams. We studied pharma, sir, we are not remembering anything. No, there are certain things, at least basic things you can remember and go and write. So anything ending with lol is a beta blocker, but which one is cardioselective beta blocker and which one is non-selective beta blocker? A simple understanding. Now remember, all of them end with lol. Any drug, the name starts from A to N. It's a cardioselective. Any name starting from N to Z, it's a non-selective. Sir, what is this N for? N for nebivolol. Nebivolol is a cardioselective. And N for nadolol is a non-selective beta blocker. So if you know A, B, C, D, E, F, G, H, then you can answer this question. So any beta blocker name starting from A to N, they are cardioselective. N to Z, they are non-selective. Propranolol, non-selective. Timolol, non-selective. Now coming to the next concept, alpha plus beta blocker, there are only two drugs. The name is called labetalol. And one more drug name is carvedilol. Carvedilol, these are not only a beta blocker, they also block alpha. Now my question is, are they cardioselective? Are they non-selective? You just answer me CS or non-NS. I want your answers. Are they cardioselective or are they non-selective? Tell me, guys. Shortest acting is esmolol because it is metabolized by esterases. Longest is nadolol. The one which closes potassium channel is sotalol, and that is why sotalol belongs to class 3 antiarrhythmics. Now please remember all the beta blockers belongs to class 2 antiarrhythmics, but sotalol has another property to block potassium. It is placed under class 3. See, again, this is one exception for the rule, guys. Labetalol and carvedilol is an exception for what we have written. These are non-selective beta blockers because they block beta 1, beta 2, alpha also. So that is why we discussed this question already. Pregnant woman had hypertension, she is asthmatic. Can I give labetalol? No, because labetalol is non-selective. It can block beta 2 and cause bronchoconstriction. So please remember these two exceptions for that rule. I hope you will not forget that. Now beta blocker antidote, just now you all told glucagon. So this is the simplified understanding of beta blockers. Yes, LOL, anything ending with LOL, how to identify cardioselective and non-selective, what is alpha plus beta blocker, these are the things. Now let us move on to the next, contraindication. Sir, why are you asking contraindication again and again? They have asked, that has come plenty of times. So remember, if a patient is having head injury with cerebral hemorrhage, don't give a diuretic called mannitol. Mannitol will worsen it. If there is pulmonary edema and left ventricular failure, don't give mannitol, because mannitol increase the blood volume, ECF volume, put the workload on the heart more, and the heart will fail further. Suppose a patient has ischemic heart disease and the BP is uncontrolled, don't give cocaine. Nobody will cocaine. Patient may take it. Don't give amphetamine, but they will test you sumatriptan and ergot. Sumatriptan and ergot are drugs for migraine. Suppose a patient is having migraine headache and he is having ischemic heart disease. Can I give these two drugs? No. That is how the cases are formed. Now coming to biliary colic. Don't give morphine in biliary colic, because morphine can cause constriction of sphincter of Oddi. So the question is, can I give pethidine, sir, in biliary colic? Yes or no? I am waiting for your answers. Can I give pethidine in biliary colic? Morphine तो नहीं दे सकते हैं, तो pethidine दे सकते हैं क्या? Tell me yes or no. And morphine is also contraindicated. Suppose a patient is having head injury. Head injury, you don't give morphine also, because morphine increases the intracranial pressure and worsens it. Yes, very good. You can give pethidine in biliary colic, but not morphine. Why pethidine can be given, sir? Both are same group. Pethidine has atropine-like property. Atropine-like property means antispasmodic. They can relieve the spasm. That's why. That's why we can give it. Okay, sir. So next one, contraindication. Suppose a patient is having inflammatory bowel disease like Crohn's, ulcerative colitis, or if somebody is having inflammatory glaucoma, they have glaucoma, but there is some inflammation like uveitis. What drug I should not give? Don't give prostaglandins. Sir, why we should not give prostaglandins if there is inflammation? Anybody? Suppose there is inflammation, why I should not give prostaglandin? Tell me, I'm waiting for your answers. Hepatic encephalopathy, don't give astazolamide. Astazolamide makes the urine alkaline, and alkaline urine makes more ammonia to get reabsorbed in the kidney, and more ammonia will worsen hepatic encephalopathy. GERD, don't give CCBs. CCBs will relax the sphincter and worsen the GERD. Suppose the patient is having non-estivulation MI and unstable angina, don't give thrombolytics. Tested plenty of times. You can use thrombolytics in STEMI, but not in non-estivulation MI, unstable angina. Hemorrhagic stroke, don't give thrombolytics. You can use thrombolytics in ischemic stroke, but not in hemorrhagic stroke. All have been tested. Yes, very good, Soumya. Prostaglandin itself, they are inflammatory mediators. And that has been tested in your NEETPG 2020, that question had appeared. So these are the contraindication. I hope you understood why these questions have been asked. So these are the two tables. Try to answer more and more. Try to make mistake now. Don't make mistake in the exam hall. Now this question I want to discuss, alpha blocker, drug of choice for scorpion sting among the following. What is the drug of choice for scorpion sting? phenoxybenzamine, phentolamine, prazosin, tamsulosin. Yes, phenoxybenzamine is a non-selective alpha blocker, but mainly it is used in pheochromocytoma. Where do you use pheochromocytoma? We use it before surgery, it is pre-operative to control BP. That is phenoxybenzamine. Phentolamine is also non-selective alpha blocker, but it is reversible. Phentolamine is used in hypertension condition like cheese reaction, clone withdrawal reaction. It is given locally in case of erectile dysfunction. The drug of choice is prazosin for scorpion sting. It's a alpha-1 selective blocker. Then tamsulosin is alpha-1A selective blocker. It's alpha-1 selective blocker. It is used in BPH only. Prazosin is used in hypertension. Hypertension plus BPH patients. So if person is having both hypertension and BPH, we prefer prazosin. BPH only, the best drug is tamsulosin. But tell me, what is the common complication of tamsulosin during cataract surgery? Suppose a patient is on tamsulosin and we did cataract surgery. What complication can we expect? What is the adverse effect, guys? Come on. The adverse effect is called floppy iris syndrome. The iris become floppy. That is seen with tamsulosin. Okay. Next, coming to glaucoma. Which of the following anti-glaucoma drug acts by increasing uveous scleral outflow? Yes, answer this. Sir, why 6 options? So that this is a revision. This is not an MCQ discussion. It's mainly a revision also. Yes. Yes, very good, Pratyusha, very good. Now, which increase uveous scleral outflow? The name is 2 drugs. No, not 2 drugs. It is latanoprost. Now, latanoprost is PGF2 alpha, and that increases uveous scleral outflow. Sir, what drug increases trabecular outflow? Remember the myotics, they increase the trabecular outflow. Timolol is a beta blocker. Astazolamide is a carbonic anhydrase inhibitor. Dipivefrin is an alpha-1 agonist. All these drugs, they decrease aqueous humor production. And natrasudil is a new drug. Remember, it's an inhibitor of Rho kinase. It's an inhibitor of Rho kinase. And one adverse effect of natrasudil is it causes cornea verticillata. But tell me, what is the mechanism of natrasudil? What it will increase? Will it increase uveous scleral outflow or trabecular outflow? Please answer this. Yes. Okay, I think now it is fine. Okay. Now, anti-glaucoma drug causing increased uveous scleral outflow, macular edema, iris pigmentation, growth of eyelash are, they are nothing but prostaglandin F2 alpha drugs. 2 important drugs are latanoprost and one more drug is bimatoprost. And this adverse effect you should know. Macular edema, iris pigmentation, growth of eyelash is done by prostaglandins. Nitric oxide donor and PGF2 alpha analog drug, that is a new drug, same latanoprostine bunod. It's a new drug for glaucoma. It can cause nitric oxide donation and PGF2 alpha agonism. Yes, Pratyusha, very good. Bimatoprost, tavaprost, tafaloprost, all are same. Very good. Drug of choice for acute congestive glaucoma. Remember, it's an emergency, so I have to act fast with IV drug mannitol. If it is not there, you can give astazolamide. But first thing is mannitol. Open angle glaucoma, we use prostaglandins, F2 alpha. You know them, latanoprost, bimatoprost. Closed angle glaucoma, we do surgery. That is the best treatment. Until surgery, I can use myotics like pilocarpine. Myotics like pilocarpine can be used. Okay, so that is most important in glaucoma. Now guys, can I ask you one question? Which drug in glaucoma cause conjunctiva? In the conjunctiva they cause black pigmentation. Which drug, can you guess? Conjunctiva, black pigmentation, which drug? You should be answering. The name is dipivefrin. Dipivefrin is a prodrug and it becomes adrenaline later. Our closed angle glaucoma, it's not mainly the drugs, it's mainly the surgery. But myotics will open the angle, that's why we use it. But open angle glaucoma, it is always prostaglandins. Yes, R, you are right. Bharat, you are right. Yes, very good. Now coming to the next question. A patient, 58-year-old male patient, had a BMI of 31. His doctor started him on a drug for obesity. Which of the following is also used in diabetes? The question is, which is the drug used for obesity also, diabetes also? Because obesity, the questions keep on coming. Yes, tell me. Tell me what is the drug for obesity and for diabetes? The name is liraglutide. So the liraglutide, semaglutide, these are approved for obesity also. So if you want to become lean, liraglutide. If you want to become slim, semaglutide. Now recently one more drug has been approved for obesity. The name starts with TI. It's also used in diabetes. Tell me the name of the drug. It starts with T. If you want, I will give one more clue. And it is in newspaper everywhere. Lorcaserin is 5-HT2C agonist. It was used in obesity, but now withdrawn because of cancers. Orlistat inhibits an enzyme called lipase, and a common problem is steatorrhea. The adverse effect of this is steatorrhea. So these are the major drugs for obesity. Yes, the name is tirzepatide. So this drug can be tested because it's in the news everywhere. Tirzepatide. It's a GLP-1 and GAP agonist. It's a GLP-1 and GIP agonist. The name is tirzepatide. Very good. Now remember, semaglutide, usually tide means we don't give it orally. But semaglutide is an exception. You can give orally also. You can give subcutaneous also. The name is semaglutide. It's an exception, guys. It's an exception. Okay, so obesity, they keep on asking the drugs, and don't ever forget liraglutide, semaglutide, tirzepatide. These are very, very important. Now, I don't want to tell you all the adverse effect and make you mug up. You guess what drug will come under dry mouth, blurring of vision, urine retention, constipation, tachycardia. So are they alpha blocker, anticholinergics, or beta blocker? Match it. Because in the exam already options are there. You have to take the right answer. That's why I already given option, you match it. This is A. Tell me where should I write A? That means anticholinergics will do that. Postural hypertension, inhibition of ejaculation, nasal congestion. B. It is mainly done by alpha blockers. Bradycardia, hypoglycemic unawareness, erectile dysfunction, heart block, fatigue. C. It is beta blockers. Now remember, beta blockers mainly the fatigue. Then erectile dysfunction. In diabetics, they cause hypoglycemic unawareness. So most of the times we remember pharma means adverse effect means nausea, vomiting, diarrhea. But if you see the table, without any hesitancy, you have told what is the adverse effect we are suspecting. Yes, so this is the point. Now with that, we are done with ANS pharma. We have answered that pharma. Now come to general pharma. General pharma is also favorite in NEETPG. That means sometimes they want to make the paper tough. Sometimes some questions in general pharma will be coming. But let us analyze what is already been asked and which is going to come. What is the fastest route of absorption? What you know? What is the fastest route of absorption? Yes, tell me. 100% viability is seen with 100% is seen with intravenous route. Rate of drug absorption is given by a parameter called Tmax, and extent of drug absorption is given by a parameter called area under curve. So you have a graph called viability graph. So you will get a bell-shaped curve like this. So this is the Tmax that will give rate, and this is the area under curve which will give extent of drug absorption. The fastest route of absorption is inhalation, guys. The reason is inhalation has large surface area. Lungs have large surface area. Most of them are telling sublingual. Remember, sublingual, the space is very less. And some are telling IV also. IV has nothing to do with absorption. IV has no absorption. Then what is the question of fast rate of absorption? No, that is ruled out. Now, what routes have first pass metabolism? What routes have first pass metabolism? Obviously, oral has, and also rectal. The only oral and rectal routes have first pass metabolism. Apart from that, whatever routes you know, they don't have first pass. Sublingual, IV, IM, they don't have. Only two have this. Okay, sir, we understood the absorption part. Loading dose of a drug depends on volume of distribution. Maintenance dose of a drug depends on clearance. CL means clearance. Weakly basic drug bind to, yes, acidic drug bind to, this you have to answer me. Basic drug bind to alpha 1 acid glycoproteins. GP means glycoprotein. Acidic drug binds to albumin, that is plasma protein binding. Now the next question is, what is the drug undergoing Hoffman's elimination? Hoffman's elimination is a special type of elimination which will not depend on liver or kidney. So the names end with curium. Can you tell me the names? Curium, atracurium. If you add cis, it becomes cis atracurium. So these drugs undergo Hoffman's elimination. That means these two drugs are safe in kidney disease, they are safe in liver disease. Yes, Bharat, you are right. Acid albumin, basic alpha 1 acid glycoprotein. Okay, sir. Loading dose depends on VD, maintenance dose depends on clearance. Now tell me, a patient comes to your hospital with renal failure, kidney is not working properly. Will you change the loading dose or will you change the maintenance dose? Please answer this. Suppose a patient has come with renal failure. Will you alter the loading dose or will you alter the maintenance dose? Answer me LD, MD, that's it. I will not alter the loading dose because it depends on VD. I have to alter maintenance dose because maintenance dose depends on clearance. And drugs are cleared by kidney. So if the kidney is not working, clearance is decreased. So maintenance dose I have to decrease. That is again our NEETPG question. Yes, very good. ED50 means effective dose 50 is a measure of, you have to answer this. Effective dose 50 is a measure of what? I will give you a clue. Efficacy or potency, you tell me. LD50 divided by ED50 is nothing but therapeutic index. Lethal dose 50 divided by effective dose 50 is therapeutic index. What is TD50 means? TD50 means toxic dose 50. What do you mean by that? It is nothing but what is the dose to produce toxicity in 50% of patients. 50% of patients, what is the dose required to produce toxicity? ED50 is a measure of what? It's a measure of, yes, most of you are making mistake. It's a measure of potency. Remember, it is the dose I am asking. Whenever I tell about dose, I am talking about potency, and dose and potency are inversely proportional. When I am talking about response, I am talking about efficacy. More the response, more the efficacy. So don't make this mistake. ED50 is a measure of potency, potency, potency. Therapeutic index is a measure of safety, how safe the drug is. If there is narrow therapeutic index like lithium, digoxin, less safe. Wide therapeutic index like penicillin, more safe. So therapeutic index is a measure of drug safety. LD50 by ED50 is therapeutic index. ED50 is a measure of drug potency, and mind will tell efficacy. No, remove that from your mind. Yes, lethal dose is animals. What is LD50? LD50 means lethal dose 50. That means dose required to kill 50% of animals. We don't kill humans. That's why. Yes, Pratyusha, you are right. Kinetics of elimination. There are two kinetics, first order and zero order kinetics. Remember first order kinetics. First order kinetics. Let us write what are constant in first order kinetics. What are constant? The fraction eliminated is constant per unit time. Half-life is constant, it is same. Clearance is same. But what happens? Elimination rate. Elimination rate is directly proportional to plasma concentration. That means more the drug, more elimination rate can happen. Right. Zero order kinetics. Let us write what is constant. The amount going out is constant and the elimination rate is constant. And what about half-life and clearance? These are variable changes. How variables are? Plasma concentration is directly proportional to half-life. That means more the plasma concentration, more the half-life. But clearance, plasma concentration is inversely proportional to clearance. That means more the drug, less is the clearance. This is tested a lot of times. So let me repeat again. First order fraction F and F are same. Half-life and clearance are same, but elimination rate is directly proportional. And please remember, most drug follow this. Zero order, also called as mixed order, also called as saturation kinetics. Here constant amount will go and elimination rate is constant. Half-life and clearance are variable, and only few drugs follow that. That is watt power, warfarin, alcohol, aspirin, theophylline, talbutamol, and phenytoin. So we have summarized kinetics elimination in this table. Okay. Now coming to formulas. Sir, will they ask you this PK formulas? Yes, sometimes I told you, sometimes general pharma is tested to make the paper tough. T of is nothing but time required to reduce a drug by 50%. It is also given by 0.693 divided by K. Sir, what is K? K is called elimination rate constant. Now T half is also given as 0.693 into volume of distribution divided by clearance. Sir, what is the formula for loading dose? It is nothing but how much you require. Target plasma concentration. How much you require into, I told you, what does loading dose depends on? Volume of distribution. If they are given bioavailability, write bioavailability. F stands for bioavailability. Maintenance dose, again, it is target plasma concentration, how much you require, into clearance, how much you want, divided by F, bioavailability. But in here you have to add one more thing, that is called dosing interval. How many times in a day you have to give is the dosing interval you have to add. Sir, are you teaching all these things? Yes, they have asked this in your NEETPG only, not INICT. NEETPG only they have asked. Yes, Pratisha, very good. So I hope you got the formulas. T half, loading dose, maintenance dose, you got that. Coming to other formulas, dosing rate is also given as clearance into plasma concentration. Dosing rate is equal to clearance into plasma concentration. Clearance is given by elimination rate divided by plasma concentration. These are the other formulas. But last two you answer. How much is the half-life required to achieve steady state? How much half-lives are required to clear a drug from the body? So answer this 1 and 2. Answer 1 and 2. Now, half-life required to achieve clinical steady state is 4 to 5. Now, even the half-life required to clear a drug completely from the body is same 4 to 5. 4 to 5. Very good, Nimra. Very good, very good. To achieve steady state, it's 4 to 5. To clear the drug is also 4 to 5. Now, they may ask you this one peculiar question. 90% steady state, how much half-lives are required? If they ask you, it is 3.3 times half-life. 3.3 times. So if they're given half-life 10 hours, multiplied by 3.3. Or they can ask you 50% steady state, it is 1 half-life. Or they can ask you 75% steady state is 2 half-lives. So these are pharmacokinetic problems. Sometimes they may give. But it doesn't mean that if you don't know this, don't go with the FOMO, fear of missing out. You can skip also, but if you already studied, it's a revision for you. And don't try to now scratch your head, what is this formula and all those things. No, that is most important at this point of time. Whatever you read, please revise that, that's it. No new information because exam is in the August 11th. No new information. If you have already studied, read this formula, otherwise leave it, that's it. Walker, when the exam approaches FMG December, at that time we'll take it, don't worry. A patient is on retigabine for epilepsy. Retigabine is used for epilepsy and was not controlled. He was added phenytoin for effective control of seizures. So he's on retigabine. Somebody gave phenytoin. What changes you want to do? So what do you want to do with the dose of retigabine? Tell me. In which kinetic this is used? I didn't get your question. A patient is on retigabine for epilepsy and was not controlled. Then what is the thing? Remember, phenytoin is an anti-epileptic, but it is also an enzyme inducer. Now, what do you mean by enzyme inducer? They increase the number of enzymes. What happens if more enzymes? The drug is metabolized faster. What happens if drug is metabolized faster? The levels come down. So what should I do if I want to give phenytoin and ezogabine or retigabine together? If I want to combine them together, I have to increase the dose. I have to increase the dose of retigabine. First order kinetics, 90% वाला जो भी हमने discuss किया था, that is for first order kinetics only. So increase the dose of retigabine. So the question here is, they will ask you enzyme inducer and inhibitors. So we have made a table for that. The mnemonic, I think if you are attending some other classes, they would have given different mnemonic. If you have that mnemonic, follow that. But important inducers, I will tell you, carbamazepine, phenytoin and phenobarbital, these are anti-epileptic drugs having enzyme induction. One drug used in TB with enzyme induction property is rifampicin. Rifampicin is always tested with OCPs. Rifampicin in OCP, they can lead to contraceptive failure. And remember, chronic alcoholism is enzyme inducer, acute alcoholism is enzyme inhibitor. This much you can remember. Now the next question is enzyme inhibition. These are inducers, these are enzyme inhibitors. Again, the most important ones are erythromycin, valproate, then protease inhibitors, clarithromycin. At least remember this, and also the azole antifungals, amiodarone, these are major enzyme inhibitors. Walker, I will message you in the Telegram itself. I will tell you that date. I think it's in the August end. Okay, so there are big list, but at least minimum you should be knowing this. Inhibitors like azole, ketoconazole, amiodarone, erythromycin, valproate, clarithromycin, protease inhibitors. Now, one interaction they will ask you is omeprazole is a PPI and clopidogrel. Now, clopidogrel is a prodrug and it has to become active by the enzyme cytochrome 2C19 that will make this active. Now, the question is, can I give omeprazole and clopidogrel together? No, because omeprazole inhibits the enzyme cytochrome 2C19, and clopidogrel will not become active. This has been tested plenty of times. Right? So please keep this in mind. Now identify the true statement from log dose response curve. Now what is dose response? The name itself is telling you there is a dose and response, and there are options here. Now when you get these type of questions, don't try to see the option first. First write the efficacy wise which is first, potency wise which is first. Now there is a mnemonic for this, help. What is the help? Check the height of the graph. If the height is more, that means more efficacy. Check the side, left side means more potent. This is left side, this is right side. Now let us write that. Height, which is the most height, C, then B. Let me write like this, C, B. I think B and D look the same. And then comes A, that is the efficacy. Check the height, that's it. Potency, which is left side, A, then B, then C, then D. So we have done this. Now once you have done this, you know which is efficacious, which is potency. Now read the option. Drug B is the most efficacious. Do you think so? No. Drug A and B are equally potent. No. B is less potent. Drug C is the most potent. No. Drug A is the most potent. Drug A is the most potent. Yes. This looks fine. So that is why I told you, don't read the option. First analyze. Try to, I think they don't give pen and pencil there. Try to analyze this thing in your mind and then read the options. That's the one. Yes, Pratyusha, you're right. Okay, guys. General pharma, I think, but don't leave the marks. When you know the concept, why you want to leave the marks for this? General pharma. So you understood the efficacy and how to find out the potency. Let us move on. Yes. The next question is, now variation in sensitivity of response to different dose of a drug in different individual is obtained from. Now dose response curve are two types, graded and quantile DRC. Now a response in different people in different doses, whether we check in graded or quantile, tell me the answer. Bit tougher level, but you will answer it, don't worry. So for example, if I give 500 mg of paracetamol to someone, fever comes down. For someone, if I give 650, it comes down. For someone, if I give 1000, it comes down. So each and every individual, the response is different with a different dose. Now where do you get that? Graded or quantile? Tell me. If you don't know, take a guess. Now please understand, it is obtained in quantile because quantile is done in population and graded is done in individual. So obviously population only you can identify the variations, and also this is all or none. That means yes or no, whether the fever decreased or not, whether the person is dead or alive, that's it. Graded means if I increase the dose of adrenaline, heart rate also increase 100, 200, 300. So we do it in individual. So the answer is quantile, and most of you have given that. Pratyusha, Nimra, very good. KK, DB, Renu are very good, guys. Very good. And this question is again a NEETPG question. Not INICET, there's a NEETPG question. Okay, sir. Now let us come to antagonism. Antagonism is blocking. Antagonism between adrenaline and histamine is, tell me that. Heparin and protamine sulfate. Heparin is acid, protamine is basic. There is a chemical reaction, so the antagonism is chemical antagonism. Now what is the antagonism between adrenaline and histamine? Anybody? What is the antagonism between adrenaline and histamine? Is called physiological. Physiological. Yes, Nimra, you are right. What is the antagonism between atropine and acetylcholine? It is called competitive. What do you mean by competitive? Both the antagonist and agonist bind to the same receptor, that is M. They bind to the same site of the receptor. Antagonism between diazepam and bicucolin, they bind to GABA A at different site. So if they bind a different site, it is called as non-competitive antagonism. Non-competitive antagonism. Now this you can overcome. You can overcome and get the same response you cannot overcome. That's the meaning of this. Now if I represent a graph here, let me draw the graph. This is the response, this is the dose. Now if without any problem, this is the response I get if there is only agonist. Now if there is an antagonist, if the graph shift rightwards and parallel, I will tell it as A. If the graph becomes flattened like this, I call it as B. Now tell me which graph is competitive antagonism, which graph is non-competitive antagonism. Tell me. A, if the graph shift rightwards and parallel, you get the same response, it is competitive. If the response decreases, the graph is non-competitive. That's it. So as soon as you see the graph shifted rightwards and parallel, it's a competitive antagonism. If it has decreased in the height, it is non-competitive. Okay. Moving on to enzyme inhibition, I think you have studied in biochemistry also. It's a quick revision for you. Competitive, the Vmax remains same, Km increases. Non-competitive, the Vmax decreases and Km remains the same, because sometimes they will attach a drug and they will ask from biochemistry. That's why this is just a revision for you. Essential drugs depends on same criteria. Essential drugs are nothing but the drugs for primary and major health problems in that country. Are they safe? Yes, they should be safe. Are they affordable? Yes, they should be, depending on the need. Efficacy? Yes, true statement. What is FDC? Fixed dose combination. That means in a single tablet, I give 2 or more drugs. What is the advantage? To increase efficacy? Yes. To reduce adverse effect? Yes. To bring down resistance, for example, in case of TB. Improve patient compliance? True. This is again a question in NEETPG for you. Now, how to write a prescription was also asked in NEETPG. You have to write the RX symbol, then you have to write the tablet, syrup, suspension, then you have to write the generic name and it should be in capital letters. You have to write the dose and don't use abbreviation, you have to write the full form 3 times daily after food. So this is how you write a prescription. That is also been tested in your NEETPG. Okay. Yes. Now the next thing is ketamine. Ketamine is Schedule X drug. True or false? Tell me. Yes, it's the true statement. Now what do you mean by Schedule X? Remember X for Xerox. The drug is given in duplicate. So whenever you give ketamine, like highly narcotic or psychotropic drug, we have to give the prescription in duplicate. One is for the pharmacist and one is for the patient. So category X is nothing but it belongs to teratogenic drug. So don't confuse category X with Schedule X. That is the meaning. Schedule H meaning you have to give the drug with prescription. They are prescription drugs. That is Schedule H. All these have been tested in your exams. Yes. Then moving on to the last part, clinical trial. It's a question from PSM also, but pharma also. Let us answer this. Phase 1 trial is done mainly to test what? Tell me. Phase 1 trial is done to test mainly what? Tell me. Maximum drug failure occurs in second phase. Because in second phase we involve patient and drug may not work. Maximum tolerated dose is found in phase 1. Because who can tolerate maximum? Healthy volunteers. Who are involved in phase 1? They are human healthy volunteers are involved in phase 1. Yes, tell me, what is the aim of phase 1 trial? The aim of phase 1 trial is safety, whether drug is safe. If it is safe, then check maximum tolerated dose. Then check for pharmacokinetics. There is a trial called phase 0 trial, also called as microdosing. We use very low dose. And what is the aim of that? To check PK, pharmacokinetics. That means how a drug is absorbed, distributed. Post-marketing surveillance is done in, obviously, phase 4 trial. Phase 4 trial is also called as post-marketing surveillance. Now guys, most of you have answered this. I will ask you one question. Dose ranging are usually done in which phase? This one you should answer. Now randomized control trial, blinded means patient doesn't know. Multiple centers are involved, 20 to 30 patient. Which phase is this? RCT, blinded, 1 to 2 centers, 3 to 5 patient in phase. Which phase is this? Now dose ranging is done in phase 2 trials. Now please answer 1 and 2. I am waiting for this. 1 and 2. Remember, RCT and blinded is done in both 2 and 3. But how do I know in the exam which is 2 or 3? Please remember, if it is multiple centers, then it is phase 3. That means I will involve more people. If it is only 1 or 2 center, I involve less people. That is second phase. Sir, should I worry about number of patient? No. In the books, they have taught, sir, 300 patient, 500 patient. Every disease you don't get 300, 500. You can get 300, 500 hypertension, but you don't get 300, 500 patients of multiple sclerosis. Right? Yes. Investigation new drug application is before. Investigational drug is before phase 1. Now we do phase 1, phase 2, phase 3, then we apply for new drug application. And after new drug application, we go for another phase, and that is phase 4. And that is phase 4. I think I have covered everything in clinical trial which is required for your exams. PK is done. PK is done in phase 1. See, I have written phase 1 trial is done test safety, maximum tolerant dose, and PK. I think some are getting a lag. That's why the answers are coming late. It's okay, guys. So please put a message whether the session is becoming useful for you. Not just put a message. Dose range means, for example, I use paracetamol for fever. So what is the dose range? 10 to 15 milligram per kg. That is the dose range. So that is found out in phase 2 trial. Okay guys, so if you are liking this, please like. You can put a like button on there and subscribe to the channel. And you can also share it to your friends later on. Okay, don't worry. I will be sharing the PDF for you. Please be active, because I don't want you to tell that pharma is difficult and don't want you to lose marks from there. In aspirin poisoning, aspirin is acidic drug. Urine should be done dash. You have to acidify or alkalinize urine. So if there is acid drug poisoning, you have to alkalinize the urine so that you can make them ionized, that is water soluble. How do I alkalinize the urine? By using sodium bicarbonate. And this is again a question asked in the exam. So aspirin poisoning, I have to give sodium bicarbonate. Amphetamine usually is a basic drug poisoning. Nicotine, amphetamine, urine should be acidified. And how do I acidify? By using ammonium chloride or by using vitamin C, also called as ascorbic acid. So these are the poisons which they can ask you in the exams. Now the drugs for rare disease or rare condition is called, they are called as orphan drug. Can you give an example of orphan drug? DG-bind, DG-fab, orphan drug. What do you mean by expiry date in a drug label? So most of you are taking drugs, right? You are prescribing drugs. What do you mean by that? Meaning is there is decrease in efficacy. So after the expiry date, if you take, the drug will not work properly and there is increase in adverse effect. That is the meaning of expiry date. DB, one clue I can give you, if the drugs end with INE, they are usually basic drugs. So there are a large list of drugs, very difficult to remember, but one small clue what I can get is If the drugs end with INE, they are basic drugs. If you don't know anything, use this trick. That's it. Now coming to the next question. A 54-year-old patient is on insulin for diabetes type 2. Which of the following is the mechanism of action of insulin on its receptor? And it's a frequently tested question. Insulin acts on which receptor? It's a physiology question, not pharma question. It is an action on tyrosine kinase. Now, which will activate IP3-DAG calcium cascade, that is called GQ coupled receptor? Increasing cyclic GMP is called GS. Decreasing cyclic AMP is called GI. And activating nuclear receptor, they are nothing but nuclear receptor superfamily. So let us come back and answer these things. Now, ion channel receptor are fastest, and let me tell you what are the ion channels here. The GABA A, then the glutamate. So glutamate has NMDA, AMPA, kainate. Even the glycine is ion channel. Now 5-HT, tell me 5-HT 1, 2, 3, you have to answer. And nicotinic are these things. Then the vitamins like vitamin A and D are nuclear receptor. The corticosteroids like mineralocorticoid, glucocorticoid. The sex steroids like progesterone, estrogen and testosterone. And then PPAR. So all these are nuclear receptor superfamily. Yes, 5-HT 3 is ion channel receptor. Tyrosine kinase, it's insulin mainly. And the growth factors, any growth factor, epidermal growth factor, insulin-like growth factor, they are all tyrosine kinase. JAK-STAT is growth hormone. Now please don't confuse here. Growth factor, growth hormone are different. Growth factor mainly for cancers. Growth hormone for our growth. Then the prolactin, PL means prolactin, and cytokines, interleukins are JAK-STAT. So if you remember this, the rest all are G protein coupled receptor. The rest all are G protein coupled receptor. Yes, very good. R thyroxine also is here. Thyroxine is also nuclear receptor. Right. So along with that, you can add some of the things which are taught in physiology also. You can add with that. Second messengers is again tested. The second messengers are cyclic GMP, cyclic AMP, IP3, DAG, calcium, and nitric oxide. These are all second messengers. Okay. So that is about general pharma, which is very, very important. Okay, guys. So now we will move on to the next system, renal and CVS. Now, please understand the video is being done as a part of revision. We are trying to revise the whole pharma with this. So please be patient. If you are not able to watch now, no problem. You can watch it later also. It will be on the YouTube. The reason why you should be in the live thing is you can interact, you can ask doubts, and you can answer my queries. That's the thing. Now we'll move on to the renal and CVS. A patient have chronic liver cirrhosis and ascites. What is the best diuretic in this patient? Cirrhosis and ascites. Patient has edema, that is cirrhotic edema. What is the best drug? What is the best drug? Is spironolactone. Why spironolactone is the best drug? Because in these ascites and all, aldosterone levels are very high, so we can use lactone. What is the purpose of this question? Purpose is to understand the mechanism and site of action of these drugs. Now, acetazolamide is a carbonic anhydrase inhibitor. The site of action is PCT. So I am going in a sequential manner. Furosemide is a loop diuretic. It inhibits sodium, potassium, 2-chloride co-transport, and site of action is thick, ascending. Remember, it's ascending loop of Henle. Thiazide, they inhibit sodium chloride symport, and the site of action is early part of DCT. Spironolactone, it's an aldosterone antagonist. And the site of action is collecting duct. Amyloride, you should tell me what is the mechanism. Mannitol is by osmosis. It's an osmotic diuretic. Remember, the major site of action is PCT and loop of Henle. If both are given, go for PCT and then loop of Henle. Not only there, they can also act in tissue also. But in nephron, this is the site. Amyloride is the ENaC inhibitor. And the major site of action of amyloride is again in the collecting duct. Okay, so please remember this. Okay, so I know the mechanism, I know the site. Now let us move on to understand certain conditions which diuretic is preferred. Cerebral edema and raised ICT due to head injury. What is the preferred one? The preferred one is mannitol. But don't give mannitol if they have given cerebral hemorrhage. Don't give it. Acute congestive glaucoma also mannitol is preferred. Left ventricular failure and pulmonary edema, the preferred diuretic is loop. And in loop diuretic, what we use is furosemide. Acute mountain sickness, I told you the name is acetazolamide. Hypertension with renal failure, CKD and CHF. Remember, patient having hypertension and comorbid problems. Then what is the diuretic preferred? Then the diuretic preferred is loop diuretics. If without any comorbidity, then we use thiazide. Right? Without any comorbidity, patient is having only hypertension, give thiazide. Hypertension के साथ they have renal failure, kidney disease, CHF, give loop diuretics. Now this you have to answer. Pratyusha, that AC inhibitor will come to that later. Now I am asking you diuretic preferred. Okay, so that's why the answer is thiazide here. It's okay, make mistake, no problem. Thiazide useful in renal failure patient even when GFR is 20 ml per minute. Any guesses? Answer that. Prevent calcium renal stone and treat osteoporosis. They are thiazide. Neurogenic and nephrogenic, what diuretic can be used is thiazide. Tell me which thiazide can be used when the GFR is less. Thiazide will not cause renal failure. They don't work in renal failure. The thiazide which is useful is metalazone. Metalazone, this was again your NEETPG question. Again, if that is not there in the option, you can go for indapamide. So remember, thiazides will not work in a patient with renal failure or kidney disease. So that's why you can see here, hypertension with renal failure, we prefer loop diuretic. Okay. Chlorthalidone will not work. If GFR is low, it will not work. So only two drugs are given in the books, metalazone and indapamide. These are the two thiazide diuretics which can work even the GFR is going less than 30. Okay. Okay, sir. Now comes the adverse effect. I am not going to tell you. You should tell me. I will give the name A, B, C. So what is A? What is B? What is C? You tell me. Check and tell me. You can see here, I am asking you the diuretic, allergy, hypokalemia, hyperchloremic metabolic acidosis is the carbonic anhydrase inhibitor like acetazolamide. Ototoxicity and all the ions are decreased. Loop loots all. That means loop diuretics. Am I correct? Erectile dysfunction, decrease in all the ions but increase in calcium is seen with thiazides. So if you study like this, you are not going to miss, even though this type of questions are asked. Okay, are you clear with this? Yes. Now moving on to the next one. At least tell me which diuretics can increase glucose, uric acid and lipids. That is mainly by thiazides. If they are not given, loop can do that. But most importantly, thiazides are going to do that. Hyperkalemia and metabolic acidosis. Obviously, when potassium is high, they are potassium sparing diuretics. What are potassium sparing diuretics? The spironolactone, then amyloride, they are the one. Now tell me, gynecomastia and loss of libido, which diuretic will do this? This one, I think you can answer that. Are you not replying, guys? I'm not getting your messages. Yes, very good. Gynecomastia, it is spironolactone. Spironolactone. And remember, eplerenone is not going to cause gynecomastia. Eplerenone will not cause gynecomastia because it will not block androgen, right? Yes. Now the next is neurogenic diabetes insipidus. What is the drug of choice? Thiazides. No, in the brain. The brain is not producing the ADH. It is also called as central diabetes insipidus. The name is desmopressin. Nephrogenic, we use thiazides. Drug of choice for SIADH, the name is tolvaptan. Sir, what is tolvaptan? It's a V2 receptor blocker. Now remember, tolvaptan is the drug of choice for SIADH. Tolvaptan is also used in CHF to correct hyponatremia. It is also used in autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease. This drug is a favorite for examiner, tolvaptan. Lithium, when we use lithium for mania, there is diabetes insipidus. What is the drug of choice? The name is amyloride. Yes, very good. V1 selective drug used for esophageal varices, the name is called terlipressin. Now tell me any other drug you know which is used for esophageal varices starting with O. V2 selective drug used in nocturnal enuresis, bedwetting, von Willebrand disease and hemophilia A. The name is desmopressin. Desmopressin is a V2 selective drug which is used in other conditions also. Yes, you are right. The name is octreotide, which is a somatostatin analog that is also used in esophageal varices. So if both are given, terlipressin will be the first choice, then comes octreotide. Okay, yes, very good. Most of you have answered it. Now the next one is angina. Nitric oxide acts by increasing following second messenger. Just now we discussed, it is the cyclic GMP. Remember, the cyclic GMP is also increased by the natriuretic peptide like BNP, ANP also. What is the aim of nitrate in classical angina? Is to decrease preload. Now what is decrease in preload? Because they cause venodilation. So if they cause venodilation, there is decrease in preload, there is decrease in end diastolic volume, there is decrease in workload on the heart. The primary aim of nitrate in variant and angina, variant means the coronaries have become spasm. So they cause coronary vasodilation. And remember, the coronary vasodilation is called endothelium independent coronary vasodilation. Next thing they will ask you, will the nitrate increase total coronary blood flow? Will the nitrate increase total coronary blood flow? No. They redistribute the coronary blood flow. They don't increase the total coronary blood flow. They just redistribute. Right, sir. Inhaled nitric oxide is used in Inhaled nitric oxide is used in pulmonary hypertension in a newborn. In a newborn. In a newborn. Nitrates are not useful in dash colic. Nitrates are not useful in. Nitrates can be used in esophageal spasm, biliary colic, but they are not useful in the renal colic. Drug-free interval in nitrate is given to decrease drug tolerance. So if the receptor will become desensitized, they don't work. That's why we call it as tolerance. Yes. So this. Now guess the drug. Guess the drug. Clue are given. The one which inhibit late sodium channel and used in angina. Remember, when you are late to the class, you are lazy. The name has lazy. The name is ranolazine. So when you are late to the class, you will run and you are lazy, ranolazine. The drug which inhibits funny sodium channel and causes vision impairment. It is used in angina also, CHF also. The name is called ivabradine. Because most of the times they ask the mechanisms, that's why. The inhibitor of PFOX, that is partial fatty oxidation, the name is called trimetazidine. The one which opens potassium channel and used in angina, the name starts with N. You tell me the names with N. Calcium sensitizer used in acute CHF, the name is levosimendan. Levosimendan. Ramesh, calcium is a secondary messenger, but in case of GQ, it becomes tertiary. In case of GQ receptor, it becomes tertiary. Yes, we have a drug called nicorandil. Nicorandil, it will open the potassium. Please remember, potassium channel openers is a favorite for examiner. You got one drug, nicorandil. There are 3 drugs in hypertension which are potassium channel openers. I will tell you minoxidil. One potassium channel opener in epilepsy, the name is called retigobine, also called as ezogabine. Then they will ask you potassium channel blockers. Potassium channel blockers. Sotalol is a potassium channel blocker. Sulfonylureas, they block potassium channel, that is called ATP. So they are favorite in asking potassium openers and potassium blockers. I hope I have clarified with this, and if you okay with this, just put a thumbs up. Yes, we'll give a break. I am also tired. I will also give the break, don't worry. Okay, the last thing, then we'll take a break. Now, PSVT is frequently asked. PSVT, the drug of choice. In arrhythmia, please understand, they mainly ask the drug of choice or treatment of choice, because you are not a medicine PG or you are not a medicine specialist. Now, any arrhythmia, if they give in the exam, ask 2 questions from the MCQ, whether the patient vitals are stable or patient's vitals are unstable. If the patient is unstable, so what we do is, first we do the shock, that is DC cardioversion, and then we give the drug, that is antiarrhythmics. If the patient is stable, then we directly give the drug. So this is the simpler aspect. So patient is unstable, give the shock, then give the drug. Patient is stable, then give the drug. So PSVT, the drug of choice is adenosine. But if the PSVT and patient has asthma, adenosine can't be given, then we use either verapamil or diltiazem. Atrial fibrillation and flutter, we use beta blocker, or I can give verapamil or diltiazem can be used. But if the patient is having fibrillation and asthma, then I cannot give beta blocker. Either I can give verapamil or diltiazem. This has been tested plenty of times. Bradycardia and heart block. A favorite drug is atropine. Right. Now coming to the next one, ventricular tachycardia. The best drug is amiodarone. If it is not there, then we go for lignocaine. Ventricular fibrillation. See, fibrillation means ventricle is fibrillating. That means patient is unstable only. So that's why we give DC cardioversion. Then we give drugs. And torsades de pontes, the drug of choice is magnesium sulfate. And congenital long QT syndrome, we use beta blockers which end with LOL. Yes, so obviously the antiarrhythmic what you prefer is amiodarone first. So in antiarrhythmic topics, I know you have studied the graph and all everything, but at least you should be knowing what is the arrhythmia and what is the drug of choice. This has been tested plenty of times. So patient is stable, give the drug. Unstable, first shock, then give the drug. And these are the common arrhythmias. As an undergraduate, you should know, and you should know the drugs. That's it. In atrial fibrillation, stable vitals, then see any arrhythmia, we have to make the rhythm normal. Whatever we are giving this fibrillation flutter, beta blocker or CCBs, they control the ventricular rate. They don't allow the atrial fibrillation to come. But amiodarone and lignocaine will not work in atrial arrhythmias. Amiodarone will convert the fibrillation into normal sinus rhythm. That is called pharmacological version. So two things we will do. Number one, in atrial fibrillation, we control the rate. We don't want the rate from atrial to come to ventricle, number one. So we use AV blocking agents. Number two, we want to convert that fibrillation into normal sinus rhythm. We use amiodarone. This is what we do. This is congenital long QT syndrome. Long QT syndrome is nothing but it's a type of ventricular tachycardia. And ventricular tachycardia means heart rate is high. Obviously, we have to give beta blockers. Lignocaine is not useful in atrial arrhythmias. True or false? True. Remember, lignocaine, which belongs to class 1B, they all work in ventricular arrhythmia only. They don't work in atrial arrhythmias. Class 1A and class 3 antiarrhythmic cause QT prolongation. True. Class 1 procainamide, disopyramide, class 3 drugs like amiodarone, sotalol, ibutolide, they cause QT prolongation. That means they show QT prolongation. So this is a true statement. Now, which of the following antiarrhythmic can cause drug-induced lupus? What is drug-induced lupus? You know SLE, malar rash, joint pain. Same thing is seen when we give the drug. So which drug will do that? The drug is called procainamide. The drug name is procainamide. The drug name is procainamide. Okay, I will explain that later. So please now don't worry about mechanism. Please learn this thing now. Okay. So antiarrhythmic causing drug-induced lupus is procainamide. Now coming back to the adverse effect and tell me the CVS drug. Lung fibrosis, Blue Man syndrome, corneal deposits. Which drug will come to your mind? So lung fibrosis, Blue Man, corneal deposits. What drug comes to your mind in CVS? That drug you should tell me. Pratyusha, yes, sulfonamide, INH, hydrolazine, procainamide, all of them undergo acetylation. And in that hydrolazine procainamide, they produce more drug-induced lupus. So here the drug which comes to my mind is amiodarone. And everything has been tested in exam. Lung fibrosis, Blue Man, corneal deposits. Now what CVS drug will come to your mind? Gynecomastia and xanthopsia, yellow vision. What drug will come to your mind is dry cough and angioedema. What drug comes to your mind? Dry cough and angioedema. What drug comes to your mind are AC inhibitors like Prils. AC inhibitors, they end with Pril, they come to my mind. And hyperkalemia, hypotension, teratogenic drugs. Tell me which CVS drugs come to your mind which are teratogenic cause hyperkalemia and hypertension. Same, the prill drugs and sartan drugs. So the prill drugs are ACE inhibitors and sartan drugs are ARBs. So don't give them in pregnant women. So please understand here, your mind can detect the adverse effect. Don't think that I only know nausea, vomiting, and diarrhea in pharma. But once you face the question, 100% you will get the right answers. So don't worry. Okay, so we'll take a break of 15 minutes and we'll resume back. So we'll take a break now. Otherwise, you will have high volume of distribution. You don't want that. So break we'll take now. Now the time is 6. Let us assume 6:10 to 6:25. Okay, so we'll resume by 6:25. Okay guys, so welcome back and hope the audio video is fine. And just check and tell me whether the audio video is fine. Then we'll proceed. Just tell me. Okay, so we'll start now and start answering now. Which of the following statements is false regarding drugs used in congestive heart failure? Ambrinon is a phosphodiesterase 3 inhibitor used in acute CHF. True statement. Ambrinon, milrinone, they all are phosphodiesterase 3 inhibitor. They are also called as ionodilators. Lisinopril prolongs longevity in chronic CHF patients. True. Now, there are certain drugs which increase longevity or they decrease the disease progression. So, please remember this. Drugs to arrest or reverse the disease progression and prolong the survival in chronic CHF patients. The mnemonic is sub. Now, what are these sub drugs? S for spironolactone, and recently they have added SGLT2 inhibitors also, and all SGLT into Toxin. Then the A stands for AC inhibitor, ARBs, and R9. R9 is an inhibitor. The ARB is valsartan, and the neprilysin inhibitor name is sacubitril. And the last drug which also decrease mortality is beta blockers like carvedilol, metoprolol, bisoprolol. So these are the only three category of drugs known to decrease disease progression in chronic CHF patients. So recently they had asked the gliflozins in one of the exams. So coming to the third option, bisoprolol is a beta blocker started with standard dose in chronic CHF. False. Now, whenever you use beta blockers in CHF patients, you should start with very low dose. Because when you block beta, the cardiac contractility decreases, CHF can worsen, but we have to start with very low dose. Sir, if that is doing decreased contraction, still we are using it to decrease the RAS pathway, to decrease the effect of aldosterone. The last option is nesiritide is a BNP analog given parental. It's a true statement. So the answer for this question is C. Yes, carvedilol is non-selective, correct, but we are not worried about asthma here, right? If it is asthma, we don't give carvedilol. Right. Now coming to patient on digoxin. Now remember, digoxin is not used so commonly nowadays in practice, but it is used commonly for MCQs. Patient on digoxin presents with pulse rate of 50 beats per minute and third degree AV block. What is the next best step you will do? Tell me the answer for this. Will you give amiodarone, digifab, lidocaine, esmolol? Tell me what you want to give here. Now remember, a patient developing, now what is the characteristic specific arrhythmia with digoxin is nothing but the atrial tachycardia with AV block. So this is the characteristic or specific arrhythmia seen with digoxin. That means there is digoxin toxicity. For digoxin toxicity, the antidote is digifab, so that can be used. So the answer is B. Now lidocaine would have been the answer if they had given. Now how will you tell it is ventricular tachycardia? The beat is 50 only, right? Now 50 beats per minute means bradycardia. So it is not used. Is used if it is digoxin induced SVT, then the drug of choice is beta blockers. Amiodarone is never used in amiodarone itself worsens digoxin toxicity. So that is why the answer will be digifab or digibind. The answer will be digifab or digibind. So let me come about digoxin. All arrhythmias are seen with digoxin toxicity except the atrial flutter is not seen. Seen is the Mobitz type 2. Second most common arrhythmia seen in digoxin toxicity is called ventricular bigeminy. And what is the most specific arrhythmia in digoxin toxicity? Just now we saw atrial tachycardia with AV block. Dialysis is not useful in digoxin toxicity. True or false? True or false? True or false? True. So dialysis is not effective in digoxin toxicity because digoxin has high volume of distribution, and in drugs with high VD, dialysis will not work out. So this is digoxin for you. Now, mechanism of digoxin in heart failure, we have discussed this. It inhibits sodium potassium ATPase pump in the heart. So sodium increases, then calcium increases, force of contraction increases. But the mechanism in atrial fibrillation flutter is vagomimetic, that is AV blocking property. Now digoxin half-life, simply remember it's around 40 hours. Should we require that? Not required. Remember 40 hours. Now the electrolyte which can cause digoxin toxicity are hypokalemia, hypomagnesemia, hypercalcemia. They increase digoxin toxicity. True statement. Kidney failure, thyroid dysfunction, the drugs like quinidine, verapamil, amiodarone, and in one of the NEETPG they asked clarithromycin, they increase digoxin toxicity. True. So you have to know this in digoxin. Sir, why are you discussing digoxin in detail? Because every year in NEETPG, INICT, digoxin is favorite. That is the reason. So please remember true statements. Coming on to the next, hypertension. 38-year-old male has started monotherapy for mild hypertension. Most recent clinic visit, he complains of tiredness. So he was given antihypertensive, now he is tired, not able to complete 3 sets of tennis, and has which one of the following drug is most likely the patient is on? Take a guess. Prazosin, metoprolol, enalapril, amlodipine. Now, what drug do you suspect? Now the patient is developing sexual problem. So which drugs are going to cause sexual problem? Number 1, beta blocker. Number 2, thiazides. And number 3, alpha blocker. And number 4, clonidine. So all these sexual dysfunction. So metoprolol can cause, prazosin can cause, enalapril and amlodipine will not cause. Prazosin, metoprolol. Remember, beta blocker can cause fatigue. We have discussed that. So the answer will be B, T, as well as sexual dysfunction. The name is metoprolol. Now coming on to this hypertension, you all know A, C, T drugs. A means AC inhibitor and ARB. C means thiazides. Suppose a patient has resistant hypertension. That means you have used 3 drugs. Even with 3 drugs, the BP is not coming down. Then it is called resistant hypertension. The drug what we use is spironolactone. So that is the drug of choice for resistant hypertension. Suppose a patient has hypertension and BPH. What is the preferred antihypertensive? The name is prazosin, because it will take care of BP also, hypertension also. BPH also. A patient is having anxiety, migraine. Which antihypertensive is preferred? Obviously beta blocker, because beta blocker will take care of BP, will take care of anxiety and migraine. Now tell me, pregnant lady has seizure and BP of 220 or 110, then what drug will you give here? This is for you to answer. This is for you to answer. So seizure in a pregnant woman is eclampsia. So eclampsia, the drug of choice is MgSO4, and you can control the BP with labetalol. So for eclampsia, magnesium, and for BP, labetalol can be added. Patient has gout and hypertension. What is the preferred ARB? Now we know the ARBs end with sartan. Now which sartan can be used? Remember, the sartan that can be used is low sartan. Why low sartan in gout? Low sartan lowers uric acid. It has uricose uric action. Not only that, it also lowers thromboxane A2. Now the next is for you. A patient has gout and hypertension. Which will you avoid? Which will you avoid? Ramesh Chandra, hydralazine and isosorbate dinitrate combination. They also decrease mortality, but that is mainly in Afro-American population, not in our country. Okay. Now tell me, patient is having gout and hypertension. Which will you avoid? Obviously, we will avoid thiazides because thiazides increase uric acid. Now, which is the ARB which has PPR gamma agonism? Gamma means it is stimulated by pioglitazone, a drug used in diabetes. The name, tell me, the name is telmisartan. Suppose a patient has diabetes also, hypertension also, and which sartan do you prefer means telmisartan because it can take care of BP and diabetes also. A Nimra loop diuretic loop will come later. So if both are given in the option, I will take thiazides, avoid this, then loop. So this is what in brief hypertension and how the questions are framed in the exam. Okay. Coming to the next question, a female patient on antihypertensive drug come for preconception counseling. Which drug will you advise her to stop? Which one should she stop? Can I give methyl dopa? Yes. Can I give beta blocker? Yes. But I should not use lisinopril or ARBs. So ACE inhibitor ARBs are because they are teratogenic. Tell her not to use this. So the answer will be C, that is lisinopril. Now one thing you should all remember, they keep on asking the teratogenic drug. Now let us guess it. Now what drug can produce phocomelia or seal limb deformity? Everybody will answer the drug is thalidomide. Mobius syndrome is done by misoprostol. If you use misoprostol in pregnancy, you get this. Phocomelia is done by thalidomide. They are outdated questions, they don't come. Now tell me this drug, fetal goiter, Epstein's anomaly, hypotonia, what drug are we suspecting? Now this drug is lithium. So as soon as you saw Epstein's anomaly, you got lithium. Now mental retardation, growth retardation. Remember, if mental as well as growth both are there, it is due to alcohol intake. Even mental and growth retardation both are given. Is renal agenesis is by ACE inhibitor or ARBs. Okay. Then guess the teratogenic drug which can cause neural tube defect. I am asking you the major drug, valproate. Valproate can produce neural tube defect. Now, what is the vitamin which is added in the high risk? It is folic acid. The dose is 4000 microgram per day. You cannot prevent, but we will use it in high risk patients. If there is cleft lip, heart defects, microdactyl, that is small digits, it is phenytoin. Now the last three is meant on A, B and C. I will be waiting for your answers. Okay, so this is the revision, guys. Yes, cutis aplasia congenita is done by carbimazole or methimazole or methimazole. Premature closure of patent ductus arteriosus is done by NSAIDs, particularly if I are using indomethacin like drugs. So you should be very careful. Now, A, very good. Whenever you see depressed nose, abnormal epiphysis, you should suspect warfarin. See how automatically you are telling the answers for this. That means you read well, you require revisions. That's it. Now, antimicrobial drugs which are teratogenics, you should guess A, B, C. These are avoided in pregnant women. Tell me, cartilage damage is done by which antimicrobial drug? They are fluoxacins. Fluoxacin means fluoroquinolones. Teeth and bone damage is done by the tetracycline group. So we don't give them in pregnant. Ototoxicity and nephrotoxicity is done by aminoglycosides. Aminoglycosides we don't give in pregnant. So remember, antimicrobials contraindicated in pregnancy as fat. F is fluoroquinolone, A is aminoglycoside, T is tetracycline. And they are going to test on this. Okay. Right. So teratogenicity is frequently asked in the exams. Now coming on to the next concept, pulmonary hypertension. Which of the following drug used in pulmonary hypertension acts by blocking endothelin receptor? Endothelin receptor blockers, they end with enton. So the answer is bosentan. So the A is the answer. Sildenafil, it inhibits the number phosphodiesterase 5. Nifedipine is a calcium channel blocker and we call them as DHPs, dihydropyridines. Now riazoguat, remember whatever option I have written, all are used in pulmonary hypertension. It's a guanyl cyclase agonist. Selexipag is a prostacyclin receptor agonist. It's a prostacyclin agonist. Selexipag. Epoprostinol, anything having prost, treprostinil and iloprost, they are prostaglandin I2. And I discussed inhaled nitric oxide is used in pulmonary hypertension in newborn. And please see all these drugs what we have written, they are for pulmonary hypertension problem. They are for pulmonary hypertension issues. So I have done with hypertension, I have done with arrhythmias, I have done with CHF, we have done with angina, most important drugs. Now guess the drug. CVS drug. I want you to guess the CVS drug. Gum hyperplasia, pedal edema and constipation. What drug comes to your mind? Yes, Pratyusha, treprostinil, iloprost are also used. PGI2, correct. Now gum hyperplasia and pedal edema, if I suspect calcia. Yes, we have a drug by the name phenytoin can cause gum hyperplasia, and immunosuppressant called cyclosporin can cause gum hyperplasia. So these two can do that. Sir, headache, tachycardia, tolerance, flushing, constipation. Which drugs will come to our mind? The mind tells nitrates. These are vasodilators, so headache, when the BP falls, tachycardia, when you use it repeatedly, tolerance, vasodilation, flushing, smooth muscle relaxation, constipation. Now, two drugs, drug-induced lupus, I have told you already. One is hydralazine, which is used in hypertension. And one more antiarrhythmic drug, which is commonly known for that, is procainamide. They cause, right? Yes, Nimra, ship drugs, but in ship, H and P are most important. Okay? And you have done your jobs. Now let us move on to a small topic in between breaks. Autocoids. Autocoids may be a small topic, but even 1 mark is important for ranks. Let us see. Drug triptans. Sumatriptan, you know they are used in migraine, but what is the mechanism, sir? They are 5-HT 1B 1D agonist. Not only that, they also decrease CGRP, calcitonin gene related peptide. Buspirone, it's a 5-HT 1A partial agonist. partial agonist. Don't confuse buspirone with one more drug. One more drug, bupropion. Now, bupropion is an atypical antidepressant. It is called as NDRI. It is used in smoking cessation also. The name is bupropion. Snake, buspirone. When you see snake, anxiety. So, buspirone is for anxiety. That is chronic anxiety. Remember they block 5-HT2. They are antagonist. Cetron, you should tell me. Revision. If you are getting it wrong, just revise. Cetron, remember they are 5-HT3 blockers. And cisapride, mosapride, procalapride, tegacid. It's okay if you forget them also. Now we are not using them. They are mainly 5-HT4 agonist. Particularly they will test procalapride. In NS side, they inhibit the enzyme COX. Tell me a drug which inhibit the enzyme LOX. So please tell me a enzyme inhibitor of LOX. This what drug inhibit LOX? Yes, the name has Luton. It's a leukotriene antagonist. Xyluton. Very good. The COX inhibitor, that is aspirin. Now, what is NS side known to cause acute liver failure? Anybody? Side known to increase the risk of MI. Yeah, tricky question, but you will answer that. Tell me, acute liver failure, hepatotoxicity, paracetamol, PCT. Paracetamol is also called as acetaminophen. Now, what drug increase risk of MI in NS sites? They are nothing but the coxib drugs. Coxib, rofecoxib, valdecoxib. Now they can increase the risk of MI because they reduce the PGI2. They reduce PGI2 levels. The next question is gout. Very, very important. Small topic, but very, very important. So let us discuss acute gout, emergency. So acute gout, we use 3 drugs. NSAID, then colchicine, steroids. Now acute gout drug used which acts by inhibiting both neutrophil chemotaxis and microtubule polymerization. Colchicine. It sounds like a Chinese name, colchicine. Acute gout, what is the NSAID used? NSAID commonly used is diclofenac. You can use indomethacin. Any NSAID can be used. But the question is, which NSAID is contraindicated in acute gout? Aspirin. Sir, why aspirin is contraindicated? Because aspirin itself increases uric acid. That's why. Yes, very good, Nimra. The colchicine main adverse effect is diarrhea. Now, why it is important? Because that's the dose-limiting toxicity. Sir, what do you mean by dose-limiting toxicity? If I increase the dose of colchicine, diarrhea also increases. That's why. So, remember 3 drugs for gout: colchicine, NSAID, and steroids. But NSAID that is not used is aspirin. Please remember it. Coming to chronic gout, the drug of choice for chronic gout is allopurinol. So I remember it as allopuri. Now this inhibits an enzyme called xanthine oxidase. One more drug which can be a blocker of that is febuxostat. So these are the drugs which inhibit the enzyme xanthine oxidase. Now, what drug increase uric acid excretion in urine? They are called uricosuric drugs. 2 drugs, at least remember it. Probenecid and a drug called lesinuride. So they are uricosuric drugs. Now tell me one drug in ARB which can cause uricosuric action. The name is losartan. Now coming on to the gout enzymes. Now we use enzymes in gout. Remember, if there is chronic refractory gout, what is the enzyme used? I'll give one number to this. If there is tumor lysis syndrome, there is increase in uric acid, then what enzyme do you use? Please answer 1 and 2. Let me see how much you understood. Please answer yes. Now for chronic refractory gout, the drug that is approved is Loticase. And the fastest acting in tumor lysis is Rasburicase. Rasburicase. And Rasburicase is not approved in gout. And Pegloticase is not approved in tumor lysis. Both have the same mechanism. They make uric acid into allantoin, but this is their indication. So never miss a mark in gout topic. Now coming to the prostaglandins, can you tell me the drug which is used to treat erectile dysfunction also and to open PDA? So the drug which can be used for erectile dysfunction and open PDA is alprostadil. Alprostadil is a PGE1 analog. Misoprostol is also E1 analog. Misoprostol is used in postpartum hemorrhage, induction of labor, that is to make cervix primed, cervical priming, and it is also used in peptic ulcer disease. Now dinoprostal ends with 1, but it is not 1, it is 2. And dinoprost and carboprost are F2 alpha. Remember, these are mainly used in PPH. I told you F2 alpha should not be used in asthma patient. That is what they are testing you. Latanoprost, bimatoprost, you know, they are also PGF2 alpha, but they are used in glaucoma. The Thai drugs, treprostinil, iloprost, epoprostinol, they are PGI2 and they are used for pulmonary hypertension. So in this one slide, we have covered the most important prostaglandins and what are their derivations. What are their derivations? But one point you should remember in prostaglandins, they should not be used if there is inflammation. Second, alpha should not be used, carboprost should not be used, dinoprost should not be used if there is asthma patient. Yes, so that is prostaglandin. Now coming to migraine, a common problem, so obviously drugs will be asked. Drug of choice for acute attack of migraine is triptans. So you can start giving triptans. They are the drug of choice, any triptan. Most common drug used for prophylaxis of migraine is the beta blocker, that is propranolol. What is the anti-migraine drug given? Patient came with low pulse and ischemia of lower limb. So tell me, what is the drug and what is the treatment of this condition? So anti-migraine drug was given. Patient came with low pulse and ischemia of lower limb. What is the drug and treatment of the condition? Remember, the drug is ergot, that is ergotamine group of drugs. They cause vasoconstriction. That is why there is low pulse and ischemia of lower limb. The treatment is to give vasodilator. Obviously, there is vasoconstriction, you give vasodilator. And the commonly used vasodilator is sodium nitroprusside. The reason is sodium nitroprusside is an equal dilator of artery and vein. So nitroprusside is preferred because it is given IV, short acting, and it can dilate both artery and vein. Suppose ergots are not there in the option, then the next option will be triptans, because triptans also cause vasoconstriction. And that is why triptans and ergots should never be given if the patient is having ischemic heart disease or uncontrolled hypertension. Now, anything new in migraine? Yes, you should know. Recently, there are CGRP antagonists used in acute attack of migraine. Remember, in attack of migraine, CGRP antagonist used, they end with G-PANT. So it's an emergency G-PANTs. For example, Ubro G-PANT, Rime G-PANT. So anything ending with G-PANT is for emergency. Now, same CGRP mechanism, prophylaxis they are used, they are MABs. So if they give MAB, remember they are for prophylaxis, they end with Nazumab. So Nazumabs are for prophylaxis, but one doesn't end like that, the name is Erenumab. So remember, prophylaxis we use MAB, attack we use G-PANTs, the mechanism is same. Now the last one is 5-HT1F agonist used in acute attack of migraine. The name is lasmiditan. Now, why did they come with this drug lasmiditan? Lasmiditan will not cause vasoconstriction. Triptans will cause vasoconstriction. then ergot will cause vasoconstriction. Lasmiditan will not do that. So suppose somebody is having heart disease and migraine attack, then we can use lasmiditan. It's a 5-HT 1F agonist. So that is about migraine. I think you have studied this in medicine also. You have studied in other revision series also. So please listen, try to recall, try to answer. Okay, that is the purpose of this session. Yes, next one is rheumatoid arthritis. Again, the drugs in rheumatoid arthritis are asked. Tofacitinib. What is the mechanism of tofacitinib? TNF alpha inhibitor? No. NIBs. They are inhibitor of Janus kinase. They are JAK inhibitors. So let us do one thing. Let us see what are the drugs in rheumatoid arthritis. But tell me, what is the drug which inhibits dihydrofolate reductase used in rheumatoid arthritis? The name is MTX. What is MTX mean? Methotrexate. So mechanism of methotrexate has been plenty times tested. It's an inhibitor of dihydrofolate reductase. So let me tell you what are the drugs and target. MABs, Infli, Sertoli, Adali, Goli. So you can make a song with that. Infli, Sertoli, Adali, Goli. One exception is etanercept. They are all TNF alpha blockers. Now before starting this, you have to rule out hepatitis B and you have to rule out latent TB. Rituximab, the target is CD20. So it's a CD20 blocker. Tocilizumab and sarilumab, they are interleukin 6 blockers. Abatacept, belatacept, they are CD80/86 inhibitors. These are called as biologicals. Now any NIBs, they are inhibitor of JAK. So this will be our revision part. Okay, so these are biologicals used in management of rheumatoid arthritis. The non-biologicals, they are called DMARDs, biological DMARDs. The non-biological DMARDs, methotrexate is the first choice. If patient is not improving, we add sulfasalazine. Not improving, we use a drug called leflunomide. Then we come to biologicals. And they will ask you these things. Okay, so is the target. Okay, let us move on. Now this is again the target. So what I have done is I have done the specialty and I have asked them. Now guess the number. Calcineurin inhibitor, can you get it from the option? Which are calcineurin inhibitor used as immunosuppressant? Yes. The name is cyclosporin and tacrolimus are calcineurin inhibitor used as immunosuppressant. My only request is don't confuse with cycloserine. Cycloserine is for tuberculosis, TB. Okay. Now the second one is mTOR inhibitor. mTOR inhibitor is sirolimus. Number 3, interleukin 2 or CD25 antagonists are basiliximab and daclizumab. Now, what is the immunosuppressant which causes DISM? The name is cyclosporin. Number 5, inhibiting dihydroorotate dehydrogenase is nothing but leflunomide. The drug which inhibits inosine monophosphate dehydrogenase, it is mycophenol mofetil. So these are all immunosuppressant drugs. In one line, we have made the mechanisms. They don't ask in detail all these things. They will ask you the mechanisms here. Okay, guys. Okay. Remember, when a patient comes with rheumatoid arthritis, first thing we give methotrexate. Not controlled, we use sulfasalazine. Not controlled, we use leflunomide. Then we go for biological agents. That's it. Now let us play the 50-50. Why 50-50? Because in the exam, We can rule out two options, but we will be left with another two options, this or that. So I think most of you will answer this. Let us make it fun. Given the condition here, I have given the condition this side, and I have asked you the drug preferred. Tell me, if driver has allergic rhinitis, will you prefer phenyramine or fexofenadine? I'll prefer fexofenadine because it's a second generation antihistamine. Phenyramine I don't prefer because it's first generation antihistamine which can cross blood-brain barrier and can cause sedation, and he is always also a driver, and if he sleeps he will make another 20 people to sleep, so we don't want that. Now if a patient is having anterior and glaucoma, now this one you should answer. Will you give latanoprost or timolol? I'll be very happy if you're answering this. Anterior is also glaucoma. What will you give? See, I am not creating this. These are already created. I am just summarizing this. I will prefer timolol. I don't prefer latanoprost because latanoprost is prostaglandin. Uveitis is inflammation. I don't want to give it in inflammation. That's why. I think most of you don't get it. A CKD patient needs analgesic. So he has chronic kidney disease and he has some pain. Will you prefer paracetamol or diclofenac? I will prefer paracetamol because it doesn't interfere with kidney function. I don't prefer diclofenac. Biliary I have discussed. Will you prefer morphine or pethidine? Morphine will worsen it. I prefer pethidine. Liver disease, will you prefer lorazepam or diazepam? I will prefer lorazepam. I will not prefer diazepam. Liver disease, some benzodiazepines are safe. Lorazepam, oxazepam and temazepam. Oxazepam and temazepam. These are safe in liver disease. And I am not getting any of your answers, guys. And all these questions are already been asked. I am not framing these questions. They have already been asked. That means you require revisions. And pharma is volatile. And the way you read in the notes is different. The way we are approaching today is different. So tell me, how did you feel this 50-50 version? Put a thumbs up if you like it. Give me your feedback. And I think now it is okay. Let us move on to the next question. Patient came with 2 to 3 loose stools. So patient came with 2 to 3 loose stools, no fever. Will you give ORS or oral antibiotics? Obviously, I will give ORS. There is no fever, then there is no requirement of antibiotics. So I will prefer ORS. I will not give antibiotics as there is no fever. To close PDA, I will use indomethacin. I will not use alprostadil. Parkinson disease patient is vomiting. I will not use metoclopramide because it crosses blood-brain barrier and blocks dopamine and worsens Parkinson disease. I will prefer domperidone because domperidone will not cross blood-brain barrier. The last question is for you. 5-year-old with viral fever, will you give acetaminophen or aspirin? Now, never give viral fever aspirin because aspirin viral fever can cause Ray's syndrome. So what I prefer is paracetamol. Now moving on to the next condition, Raynaud disease. Which is preferred? CCBs are the drug of choice, so I can prefer this. Nitrate is not a contraindication, but the better is CCBs. Acute gout, I will prefer diclofenac. I will not give aspirin. Aspirin worsens gout. Suppose there is a thyroid storm during surgery. There was thyroid storm. The body temperature went up. to come down the, to bring down the body temperature, will you give paracetamol or aspirin? I will give paracetamol. I will not give aspirin. Why? Aspirin itself displaces the thyroid hormones from the binding protein. They release more thyroid into the circulation. So aspirin should not be used to control temperature in thyroid storm because it increases the thyroid hormone levels. That's why. Right. So this is how we analyzed. Again, these are questions. This is how the questions are made. Understand. Condition and drug preferred. Post MI, patient in MI. Now he is having severe gastritis. Now in this patient, for aspirin or clopidogrel, tell me. Will you prefer aspirin or clopidogrel? Now I will prefer clopidogrel because aspirin is an NSAID which can cause gastritis. I cannot give it. Post MI patient with poor metabolizer status of cytochrome 2C19. Now remember, clopidogrel is a prodrug. It has to become active with the help of cytochrome 2C19. It becomes active. Suppose the patient enzymes are very poor, then clopidogrel will not work in this patient. So I will not give this. I will give aspirin. Now the question is, suppose a patient has valvular heart disease and atrial fibrillation. So valvular heart disease can be mitral stenosis, can be a prosthetic heart valve. So valvular heart disease meaning patient may have prosthetic heart valve or patient may have mitral stenosis, atrial fibrillation. That means formation of clot, and a clot may dislodge and go to the brain and stroke. So what is the drug I can use? The drug I can use is warfarin. Now we never try this new drugs like dabigatran, apixaban. These are not used. So what I use is warfarin. Suppose there is non-valvular heart disease and atrial fibrillation. What I prefer is Novax are better. But if it is valvular heart disease, warfarin is better. Right. So this is how we come to the conclusions. Okay, super amazing, thank you. So it will be more amazing when you answer in your exams. Okay guys, so that is about the 50-50. Now drug interactions. Now drug interaction can be good also, bad also. Now why do we combine imipenem and cilastatin together? When we combine them together, the imipenem will act longer. That's the point. Amoxicillin and clavulanic acid, yes, it's a beta-lactam, beta-lactamase inhibitor, so we can use them in combination. Erythromycin and theophylline should never be used. Erythromycin is an enzyme inhibitor, so theophylline levels increase leading to adverse effect. Phenytoin and sucralfate, can we give them together? No, but if you want to give them together, you have to give a gap of 2 hours. You have to give 2 hours gap. This has been asked in INACT. Methotrexate, folinic acid, obviously, yes, we give it to prevent methotrexate toxicity. Can I give verapamil and metoprednisolone? Never. Because verapamil is also going to decrease the heart rate, conduction. Metoprolol is also going to do the same. So patient will develop severe bradycardia and heart block. Nifedipine plus metoprolol, can we use them together? Yes, because nifedipine decrease the BP and increase the heart rate. Metoprolol decrease the heart rate, so this increase in heart rate is compensated by decrease in heart rate, so you can use it. But this has been tested in your exam, verapamil and metoprolol, erythromycin and theophylline, imipenem and cilastatin, these are being tested in your exams. So if you want, I will tell you some other interactions. Please listen. Aspirin is an antiplatelet drug. Warfarin is an antiplatelet drug. Can we give them together? Yes, you can give, but the risk is bleeding. So you should be very careful when you give them together. Lithium and thiazide diuretics, can you give it? No, they can cause lithium toxicity. Tetracycline and antacid, never give them because they decrease the tetracycline absorption. tetracycline absorption. Iron plus vitamin C, yes. Acid environment favors iron plus PPI, don't give it. OCPs and rifampicin, no. Contraceptive failure. Omeprazole and clopidogrel, no, because omeprazole will not allow clopidogrel to become active. Sucralfate and antacids, no, because sucralfate require acidic pH for activation. Antacids will not allow the pH to be acidic. I think most of you know this. I'm just highlighting what you already know and you read in MCQs. So I hope you got the logic here. Nimra, why gap of 2 hours? A very good question between phenytoin and sucralfate. 2 hours gap. Now the question is, now this is the esophagus, stomach. So what happens if I use sucralfate? Sucralfate will coat the stomach like this. Now if the patient takes immediately phenytoin, phenytoin cannot get absorbed because the ulcer and the stomach is coated. So that is why you should give at least 2 hours gap to avoid the decreased absorption of phenytoin. That's why. Now coming to levodopa plus carbidopa, obviously we can give it. Levodopa plus B6 should not be given because B6 is pyridoxine, which will convert levodopa to dopamine outside only. And more dopamine is going out, not into the brain. Ezetimibe plus statin, yes, you can give them, but this is tested. Nitrate plus sildenafil, can we use them together? No, because both of them increase cyclic GMP and there is severe hypotension. This is tested in your exam. Allopurinol and 6-mercaptopurine, can we give them together? Yes. Applied by xanthine oxidase. 6-mercaptopurine is metabolized by xanthine oxidase. So if I give them together, allopurinol inhibit this. So what happens? The 6-mercaptopurine level increases and lead to toxicity. So what should I do so I don't get toxicity? Tell me the answer for this. Allopurinol and 6-mercaptopurine should not be given together. If I give them, the levels of this cancer drug increases and leads to toxicity. So what should I do? And still I can give them together. Tell me, should I increase the dose, decrease the dose, same dose? So that is why you have to decrease the dose of 6-mercaptopurine and give it. Okay, so these are the interactions and I will give you the PDF again. And you can again see it. Okay. Now let us move on to the next topic, the antimicrobials. Antimicrobials, a very important topic, repeatedly asked. Which of the following drug acts by inhibiting cell wall synthesis? Now, whenever they ask you the mechanism, now understand in your mind whether the drug works on cell wall, whether the drug works on cell membrane inside, whether the drug works on protein, DNA, or it works on the metabolism. What is the drug acts by inhibiting cell wall synthesis? Anybody? Tell me, what drug inhibits cell wall synthesis? The beta-lactam drug cephalosporins are going to inhibit cell wall synthesis. So let me tell you what are the drugs. I have already written the mechanism of action and the drugs here. Inhibiting cell wall synthesis, 2 drugs you should remember. The name is beta-lactams and vancomycin, that is glycopeptides. Now, beta-lactams, they inhibit an enzyme called transpeptidase. And vancomycin inhibit an enzyme called transglycosylase. Now, acting on cell membrane, we have 2 drugs. Number 1, colistin. and a drug called daptomycin. Inhibition of protein synthesis, the one which binds to 30S and one which binds to 50S. 30S, you remember the team. What is team for? Tetracycline, AM for amyl glycoside. Then we have the drug called chloramphenicol. And we have a drug by the name linezolid. And MCQ drugs, MCQ. So what is MCQ? M for macrolide like azithromycin, C for clindamycin, Q for quinprestin and alfaprestin, that is called streptogramins. Now moving on to the next one, the one which inhibits folic acid synthesis, they are sulfonamides, dapsone and PAS. S is sulfonamide, dapsone and PAS. The one which inhibits dihydrofolate reductase, remember them as PMT. P for proguanil and pyrimethamine, M for an anti-cancer drug methotrexate, and T for trimethoprim. T for trimethoprim. The one which inhibit DNA gyrase and topoisomerase 4, they are fluoroquinolones and they end with floxacin. Now the one which inhibits transcription of DNA to RNA, DNA-dependent RNA polymerase is inhibited by an anti-TB drug. The name is called rifampicin. Rifampicin. So I think the internet is fluctuating too much. Just a minute. Okay, the internet is fluctuating too much. Just a minute. Hold on. Okay, so I think you are now audible. Am I audible? Yeah. So P is proguanil and pyrimethamine. And DNA-dependent RNA polymerase is inhibited by the drug called rifampicin, which is an anti-TB drug. So hope you got the mechanisms now: cell wall, cell membrane, protein, then the folic acid synthase, dihydrofolate reductase inhibitor, then DNA gyrase and DNA-dependent RNA polymerase. Now let us move on to the next question. In the newborn, the drugs. Which of the following antibiotics can cause bilirubin displacement and lead to kernicterus in newborn? Can you answer this? Yes. So the drug which can cause bilirubin displacement, they are sulfonamides. So here the example is sulfamethoxazole. Now chloramphenicol can cause a syndrome called gray baby syndrome. So it can cause the gray baby syndrome if you are using in premature babies. Tetracycline, I have discussed, it mainly causes teeth and bone damage. So amoxicillin is safer, you can give in this. But bilirubin displacement is caused by sulfa drugs like sulfonamides, sulfamethoxazole. Now coming to the guessing, you have to guess the adverse effect. Hypersensitivity, that is type 1 hypersensitivity mainly, is done by the group of drugs called beta-lactams. Particularly the penicillin group of drugs are known to produce the type 1, that is anaphylaxis. Zahrich-Charzimer reaction is a reaction seen when you give penicillin to treat syphilis. Remember, it's not an anaphylaxis, it's an inflammatory response. So for Zahrich-Charzimer reaction, we use the aspirin, that's it. Disulfiram-like reaction, bleeding risk, reducing the prothrombin. The drugs are cefamandole, cefotitan, and cefoperazone. So disulfiram means patient should not take alcohol. Remember like this, if a man becomes tetan, तो डोल बजाएगा, डोल कहाँ, operazone. So these cephalosporins are known to produce disulfiram-like reaction. Tell me one antiamoebic drug which can cause disulfiram reaction. The name is called metronidazole. So this has been tested plenty of times. Metronidazole and alcohol for disulfiram-like reaction. Disulfiram-like reaction. Now you should tell me tendon rupture, cartilage damage, and seizures. Which drug comes to your mind? Which drug comes to your mind? Tendon rupture, cartilage damage is the fluoroquinolones like fluoxetine. Redman syndrome, ototoxicity, and nephrotoxicity is vancomycin. Allergy, Stevens-Jones syndrome, bilirubin displacement, and crystalluria is mainly done by sulfonamides. So there is something called buzzwords which will come in the exam. So you can identify what drug will produce this adverse effect. So don't worry about that. Right? Yes. Now let us move on to other adverse effect. Ototoxicity, nephrotoxicity, and neuromuscular blockade is done by the aminoglycoside. AGs means aminoglycosides. Now, which antimicrobials can cause QT prolongation? Remember one TB drug called bedaquiline. Then the fluoroquinolones, and then the macrolides, and the HCQ, hydroxychloroquine, they can cause QT prolongation. There are plenty, but most important ones you should remember. MAO inhibition, bone marrow suppression, and thrombocytopenia is done by linezolid. Teeth discoloration, bone damage, vestibular toxicity, diabetes, photosensitivity is tetracycline. Remember, tetracycline causes so many adverse effects. Now, this will be tested. Bone marrow depression, at least you should remember this. It is done by linezolid. Then the drug called chloramphenicol. Then the HIV drug zidovudin. And ganciclovir, which is used in herpes. So remember, we have made a table and we have given the drugs which will do that. Okay. Okay, so we'll move on. Yes. A 24-year-old pregnant woman present to the clinic with fever, frequency of urgency, UTI. So she is a pregnant woman, UTI. Which of the following medication should be avoided? So I think we have discussed this. The fat drug should be avoided in pregnant women. Fluoroquinolones, amyloxicillin, tetracycline should be avoided. You can give Furantine, amoxicillin, you can give cefixime, Remember, the safest in pregnant women are PCM. P for penicillin, C for cephalosporin, and M for they are macrolides. Now let us come to the drug of choices because the questions are not direct now. Patient came with fever, chills, rigor, Widal test positive, that means typhoid. The drug of choice is ceftriaxone. Suppose there is a carrier of typhoid, then the carrier is given ciprofloxacin. See, PCM is not paracetamol, it's a mnemonic. PCM are safe in pregnancy. Patient with cough, fever, and due to atypical bacteria like mycoplasma, then what is the drug of choice? Atypical pneumonia by bacteria, the drug of choice is azithromycin. There was an outbreak of MRSA in the hospital. What is the drug used to eradicate nasal carriers? So nasal carrier eradication, what we use is mupirocin. Now if it is not there, we can use bacitracin. This is for the carrier eradication, but the drug of choice for MRSA will be vancomycin. Okay. Then moving on to the case 4, patient was given clindamycin to treat anaerobic infection. After 4 days, he developed diarrhea due to Clostridium difficile. Now this is a problem called pseudomembranous colitis, and the drug of choice is oral fidaxomicin. Oral fidaxomicin. If it is not given, you can go for oral vancomycin. Oral vancomycin. Patient came with fever, headache, and neck stiffness. Brudzinski sign and Kernig sign are positive. Empirical drug of choice for suspected bacterial infection. Remember, empirical drug of choice for meningitis is ceftriaxone. But ceftriaxone will not work in listeria. If the meningitis is listeria, ceftriaxone will not work. For listeria, the drug of choice will be ampicillin. Now coming to the infections, pertussis or whooping cough, the drug of choice is azithromycin. Diphtheria, the drug of choice is diphtheria antitoxin. If that is not an option, then you can use the erythromycin drugs. Erythromycin. Rickettsia, any typhus, scrub typhus everywhere, the drug of choice is doxycycline. Leptospirosis, also doxycycline is used. Enterococcus faecalis and listeriosis, I told you the answer is ampicillin. And H influenza, what is used is ceftriaxone. So these are the drug of choice for the infections. Now moving on to the STDs. Again, the STDs are tested. Gonorrhea and chancroid, it is ceftriaxone. Non-gonococcal urethritis, ceftriaxone will not work, so we use azithromycin. Syphilis, all stages, we use benzathine penicillin. But neurosyphilis, benzathine cannot cross blood-brain barrier, so we use aqueous penicillin. Chlamydia, lymphogranulovenerum, and granule inguinal, we use the doxycycline. If it is not there, we use azithro. The last two you should tell me, trichomoniasis and genital herpes, what we use. Trichomoniasis, what we use. Brucellosis, also doxycycline. Trichomoniasis, we use the drug metronidazole. So you see the strawberry cervix. Herpes, we use acyclovir. So this is the things. Gonococci, it is ceftriaxone. Right. Now coming to the TB drugs. Which of the following drugs used in TB acts by inhibiting mycobacterial ATP synthesis? The name is bedaquiline. Bedaquiline is the one which inhibits ATP synthesis. Two important adverse effects of bedaquiline is it can cause QT prolongation and it can cause liver toxicity. Now remember, isoniazid inhibits the cell wall. In cell wall, it inhibits mycolic acid. It inhibits mycolic acid synthesis. And the major adverse effect of isoniazid is, you can remember the INH. It inhibits the enzyme. N for it causes peripheral neuropathy, and you can treat it with B6. H is it is hepatotoxic. Rifampicin inhibits DNA-dependent RNA polymerase. DNA-dependent RNA polymerase. And remember, rifampicin starts with R, so it can cause red discoloration. What red? Orange discoloration of all the secretions. Even urine will become red color. Pyrazinamide also inhibits cell wall. They don't ask the mechanism of pyrazinamide. But remember, pyrazinamide P, it starts with P for pain. What pain? Joint pain. Why joint pain? Because it increases uric acid. Ethambutol also inhibits cell wall. It inhibits arabinogalactone synthesis. And remember, ethambutol for eye problem. It can cause optic neuritis, and that will lead to red-green blindness and decrease in visual acuity. So these are the major drugs what they keep on asking you. Remember, isoniazid, INH, only you know the adverse effect. Peripheral neuropathy treated with B6, hepatotoxicity. Rifampicin, red discoloration of secretions. Pyrazinamide, pain, joint pain due to high uric acid. Ethambutol, eye problem, that is neuritis, patient will have red-green blindness. Bedaquiline, QT prolongation and toxic to the liver. Right, so if I ask Nimra, yes, you are right, hepatotoxicity, pyrazinamide is more than isoniazid, then rifampicin is the least one. Okay, yes. Now moving on to the next aspect, sometimes we have confusion with this. Remember, any drug ending with prazole, they are PPIs, like pantoprazole, like that. Any drug ending with P-prazole, for example, aripiprazole, is an atypical antipsychotic. Because if you see the names, almost all the names end with azole. If they end with bendazole, like albendazole, they are antihelminths. Many a times we make mistake in identifying the drug only, then how do you get the right answer? Nidazole is like metronidazole, they are for amoeba or they are for antiprotozoal. Now conazole, if they end with conazole, they are antifungal, like fluconazole, oriconazole, like that. If they end with ozole, for example, letrozole, they are aromatase inhibitors used in breast cancer. So please have clarity with azole. Even we have carbimazole, methimazole. They are used in hyperthyroidism. Okay, they are used in hyperthyroidism, carbimazole, methimazole. Now let us come to certain cases here. Fever for 1 week, abdominal distension, loss of appetite, not responding to antibiotics, antimalarial, RK39 dipstick was positive. What is the drug you can be used in the condition? So first of all, what is it? It is visceral leishmaniasis, ulcer. So what is the drug of choice for that? Is lamb. So RK39 dipstick positive means visceral leishmaniasis. So the drug of choice is liposomal amphotericin B. Right. Second, the malaria. Drug used in malaria for killing gametes. It will kill all the species gamete. Radical cure and reduce relapse. The name is called primaquine. So primaquine is a drug which will kill the gametes, cause radical cure and reduce the relapse. So you have to give 14 days for killing the hypnocytes and for radical cure. Similar drug is tafenoquine. Tafenoquine is given as 1 dose for radical cure. The reason is tafenoquine is very long acting, 14 to 19 hours. Remember one important thing I will tell you in pharma, most of the starting with T, जिसका नाम T से शुरू होता है, they are usually longer acting. If you don't know anything, then only answer that. Most of the drugs starting with T, like telmisartan, torsemide, tadalafil, tafenoquine, usually they are longer acting. But one exception is there, tropicamide, which is a mydriatic, is shortest acting. But if you don't know anything, if they start with T, write them as long acting. Now, radical cure with primaquine is not in pregnancy. True. So we never give primaquine in pregnancy because the baby is relatively G6PD deficient. Primaquine is also not given contraindicated if there is G6PD deficiency. If I give it, there is a chance of hemolysis. Now, after the person leaves endemic area of malaria, usually when you go to endemic area of malaria, you take prophylaxis. Now, the prophylaxis need to be continued for, tell me. Suppose I am taking prophylaxis. And I left the endemic area. Should I take the prophylaxis further? Yes, you take the prophylaxis for 28 days. So malaria prophylaxis is frequently asked in the exams. Let me tell you. Prophylaxis, if your travel is less than 6 weeks or more than 6 weeks. If your travel plan is less than 6 weeks, then the drug used is doxycycline. More than 6 weeks, commonly used is mefloquine. Doxy started 1 to 2 days before. This is the start of journey, end of journey. So daily you have to take doxy. But after coming from endemic area, you have to take it for another 28 days. It is taken. This is the prophylaxis. Mefloquine you can take 1 to 2 weeks before journey. This is the start. This is the end of the journey. But the advantage of mefloquine is it is taken once weekly. And coming back, you have to take 4 weekly. That means 4 weeks. So this is the prophylaxis of malaria. So you can take it before journey, during journey, and after coming back also, you have to take the prophylaxis. And doxy is taken daily. Mefloquine is taken once weekly. That's the prophylaxis. Then coming to another case, patient from northeastern state was diagnosed to have Plasmodium falciparum. What is the most appropriate drug for this patient? You should answer this. Yes, northeastern part, falciparum malaria, what will you give? Now remember, falciparum has become resistant to chloroquine already. So what we use is ACT, artemisinin combination therapy. And for northeastern state, we use a combination called artemether plus lumefantrine. Remember me. So northeastern part, it is me. A patient came from Rajasthan and has Plasmodium falciparum malaria. So rest of India also we use ACT regimen. For rest of India, what we use is artesunate plus sulfadoxine pyrimethamine combination. Remember the SU here. So there it was me, here it is SU. Right, sir. Now moving on to the next case. Patient returned from Assam, fever with chills, delirium. So he has fever with chills, confused and had seizure. He was having Plasmodium falciparum malaria. What is the most appropriate drug for this patient? So it's a case of complicated malaria because you can see the confusion, seizure. It's a case of cerebral malaria. So what is the drug of choice for this condition? The drug of choice is IV artesunate. So we use IV artesunate here. right? So these are the questions in malaria. And coming to the virus, antiviral drugs. Now the mechanisms can be asked. Integrase inhibitors, remember they end with tegravir. For example, dolutegravir or raltegravir, they are integrase inhibitors. GP41 inhibitor, the name is enfuviritide. And CCR5 inhibitor, the name is maraviroc. And entry inhibitor, there is a monoclonal antibody called ibalizumab. The name is ibalizumab. So these are the anti-HIV drugs and their mechanisms. Now moving on to the other drugs called NRTA. NRTA stands for nucleoside reverse transcriptase inhibitor. Major drug, remember, zidovudine, lamivudine, emtricitabine, and tenofovir. Tenofovir is called as nucleotide. Remember T for nucleotide, tenofovir. Why I have highlighted these LET drugs, LET drugs? These are also used in hepatitis B also. Remember, lamivudine, emtricitabine, tenofovir, they are not only used in HIV, they are also used in hepatitis B also. Then non-nucleoside reverse transcriptase inhibitors, they end with virin. But the older drugs don't end like that. The mnemonic is delaviridine, efavirenz, and nevirapine. At least remember they end with virin 1. There are two drugs, efavirenz, nevirapine, they are frequently tested. Now coming to the drugs which are protease inhibitor, which inhibit viral assembly, they end with navirs. What are navir? Like indinavir, ritonavir, amprinavir, fosamprinavir, they end with navirs. So these are the mechanisms. So coming to adverse effect. Now which anti-HIV drug can cause myopathy and nail pigmentation? Okay, so we'll continue now. Okay, sorry for the interruptions now. Let us move on. Can you tell me the drug which causes bone marrow suppression, myopathy, and nail pigmentation? The name is zidovudine. So zidovudine is one of the first drug in HIV, and that's why it has so much toxicity. Palms and sole pigmentation is done by a drug called emtricitabine. Emtricitabine. The name is emtricitabine. Metabolic syndrome is caused by which group? They are navir drugs. Navir means protease inhibitors. They can produce metabolic syndrome. What is metabolic syndrome? Obesity, dyslipidemia. Nephrolithiasis is done by indinavir in HIV, indinavir. Now, bone mineral density is reduced and GFR is reduced by the drug, famous drug, tenofovir. The name is tenofovir. So these are the major adverse effects you have to keep in your mind when you study anti-HIV drugs. Now moving on to the next thing, HIV and co-infections. HIV patient has the risk of pneumocystis cirrhosis. What is the prophylaxis? The prophylaxis is by cotrimoxazole. HIV patient has diarrhea due to drugs. What is the treatment? Remember, diarrhea due to drug, the first thing is loperamide. If that is not there, you can use a new drug called crofelemer. You can use it. Suppose there is HIV and TB co-infection. What is treated first? Remember, first treat TB. Then 1 to 2 weeks later, you have to treat HIV. So first treat TB and then HIV. Otherwise, if you treat HIV first, there is a chance of immune reconstitution syndrome. Right, guys? So this is the point. Now moving on to the next, hepatitis C. Hepatitis C, there are certain new drugs. The NS5A inhibitors, remember they end with asvir. A for asvir, 5B, B for they end with bovir. For example, sofosbuvir. NS3/4, that is protease inhibitor, they end with previrs. These are the new drugs in HIV. Not HIV, hepatitis C. The RNA-dependent RNA polymerase is inhibited by a drug called ribavirin. It's an old drug for hepatitis C. And interferon alpha is also used in hepatitis C. And hepatitis C is a question of INICT pattern. Remember, these are used in combination therapies. 5AB, 5A inhibitors, 5B inhibitor, protease inhibitor, interferon alpha, ribavirin, like this. But can you tell me the drug of choice for hepatitis B, guys? Hepatitis B, what's the drug of choice? Yes, the name is tenofovir. The name is tenofovir. Coming to other infections, particularly virus, neuraminidase inhibitor used in influenza prophylaxis and treatment. The name is oseltamivir. So most examiner have tested mechanism of oseltamivir. It's a neuraminidase inhibitor. Drug of choice for herpes 1, herpes 2 and varicella zoster is acyclovir. And cytomegalovirus, it is ganciclovir. But if they become resistant, then resistant cases, we have a drug by the name foscarnet. Foscarnet. Drugs used in RSV infections, we use ribavirin, a old drug. And there are two maps what we use. The name is called palivizumab and a new drug called nirsevimab. These are new drugs. Yes, don't get tired. Don't get tired. It's a revision part. Please keep on focusing. Now, pharma, why it looks wide? Because it's integrated everything. You read microbiology, drug of choice is this. You read medicine, hypertension, CHF, again drug. You read psychiatry, again CNS, drugs will come back. So this is why you have to consider pharma, because many a times the integration topics keep on coming here. I can do dinner now also, but please keep calm. See, our field, medical field, doesn't require intelligence. We require ischial tuberosity. Why ischial tuberosity? So that you can sit and study. There is no shortcut in our field. Okay, let us move on to the next question. Now, COVID is not there. 36-year-old female diagnosed with moderate COVID-19 was started on nirmatrelvir. Nirmatrelvir is one of the new drug for COVID. It is used with ritonavir. What is the mechanism of that? Remember, nirmatrelvir is a protease inhibitor. That's the only thing. Neuraminidase inhibitor, I have told you, it is oseltamivir. RNA-dependent RNA polymerase inhibitor, the name itself, most of them remember. What is the name of it? Yes, remdesivir. Actually, remdesivir was discovered for Ebola, then it was used in COVID-19. Don't confuse DNA-dependent RNA polymerase, that is inhibited by, the name is rifampicin. RNA-dependent RNA polymerase inhibited by remdesivir and a drug called ribavirin. Anti-inflammatory drugs like steroids were also used in COVID-19, but they decreased mortality of COVID. mortality in COVID was reduced by steroids mainly. So this is the only drug now for COVID-19. You have to remember the name is Nirma. You know the washing powder Nirma. The drug name is Nirma. So that's what I told you, Narasimha. Remember, RNA dependent means these two drugs. DNA dependent RNA polymerase means rifampicin. Please read it carefully. Now the next thing is an HIV patient, a pregnant female, delivered a baby. She is not taking any antiretroviral therapy. Which of the following should be started to the newborn? Now she is pregnant female. She is HIV positive but not taking any treatment. She delivered a baby. Remember, how to prevent mother to child? We use nevirapine usually. But since the mother is not taking any treatment, the baby is at high risk. So two drugs are used, that is nevirapine and zidovudine for 6 weeks. This is the treatment we have to give. Suppose a pregnant female is on treatment and the viral load is less. Then what we give for the baby is only one drug, that is nevirapine, is alone given for 6 weeks. That's the simplest thing you have to keep in your mind. That is the simplest thing. Remember, the drug is given for newborn, not for the mother. Not for the mother. Please remember, the question is for the newborn. So for the newborn, if the mother is already taking treatment, viral load is low, then give nevirapine alone. Mother is not at all taking treatment, viral load is high, then give combinations. I hope you got this. Now please understand, another thing they will ask you is post-exposure prophylaxis, because we are all doctors and many a times we may get pricked. We gave an injection to HIV positive patient, we are putting the cap and we get pricked. So remember, the prophylaxis should be given within 72 hours and minimum you should give 3 drugs, and the 3 drugs should be given for minimum 28 days. And the best combination is TLD. What is TLD for? T for tenofovir, L for lamivudine, dolutegravir is the best combination. Suppose that combination is not available, any other 3 drug combination can be used for post-exposure prophylaxis, because most of the exams you will be searching this combination, it is not given. Then search another 3 drug combination that can be given. Remember, started within 72 hours as early as possible, 3 drugs and 28 days. Then antifungal drugs, identify the wrong match. So my purpose of giving this MCQ is to make you understand the mechanisms. Ketoconazole, any azole drugs, they inhibit lanosterol 14 alpha D methylase, true statement. Flucytosine, it's a brother of an anti-cancer drug 5-fluorouracil. It is a drug which inhibits DNA synthesis. It will not do anything with microtubule synthesis and mitosis. So this is the wrong answer. The one which inhibit the mitosis is griseofulvin. So option B is wrong. Terbinafine it inhibits choline epoxide, true statement. Amphotericin B increases cell membrane permeability, it's also true. Now I am not discussing MCQ, I am telling you the facts here. So the mind is such, a mind is like when you give information like information, it will never take it. It will never store it. But when you give information like a question, it will store it. So that's why the reason why MCQ should be solved often. Yes, very good. Nimra Adoni, hand-foot syndrome is caused by 5-fluorouracil. Even capecitabine can cause hand-foot syndrome. Okay. Now coming to drug of choice for fungus. Yes. Now if there is allergic bronchopulmonary aspergillosis, I give steroids because to overcome the allergy. But if I give steroid alone will not suffice, I have to give itraconazole. Invasive aspergillosis, you should tell me. The answer is oriconazole. Oriconazole. Cryptococcosis, invasive candidiasis, coccidioidomycosis, you can give fluconazole. If fluconazole is not there, obviously you have to give itraconazole. Chromoplastomycosis, chromomycosis, sporotrichosis, any other, we use itraconazole. Now, the pneumocystitis cirrhosis, you should tell me. Mucormycosis and cryptococcal meningitis, we use LAMB. LAMB means liposomal amphotericin B. So in cryptococcal meningitis, it's an emergency. We use LAMB plus or minus 5-flucytosine. So remember, mucormycosis and cryptococcal meningitis, the best drugs are LAMB. Pneumocystitis cirrhosis, the drug of choice is cotrimoxazole. Nimbra, allergic bronchopulmonary aspergillosis is mainly allergic phenomenon. So steroids are the main treatment. Along with that, we don't want to take a risk, we add antifungal therapy. But invasive aspergillosis, voriconazole should be given. So this is how we manage the deep mycotic infections, frequently asked. Recently they had asked mucormycosis, pneumocystitis cirrhosis, common in HIV, cryptococcal meningitis complication, they will ask you, Rose Gardner disease, they will ask you, candidiasis, fluconazole, they will ask you, aspergillosis, voriconazole, they will ask you. So we have made everything in the chart. The last one in antimicrobial is antihelminths. You know, antihelminths are cestodes, nematodes, and trematodes. Cestodes, any cestode, the drug of choice will be praziquantel. So it's a revision for you, microbiology. Solium, Sejaneta, fish tape, or Vesna. But there is neurocysticercosis and hydatid disease. The best drug will be albendazole. Now, nematode. All the nematodes, the drug of choice will be albendazole. Filariasis, lova, the drug of choice is diethyl carbamazine. Strongyloidosis, onchocerciasis, ivermectin. Remember, ivermectin is also used in scabies. Cutaneous larva migraines also, the drug of choice nowadays is ivermectin. If it is not there, you can write albendazole as a second answer. Then cutaneous larva migraines we understood. Visceral larva migraines, the drug of choice is albendazole. Flukes, for all the flukes, the drug of choice is praziquantel. Except the liver fluke, also called as facial hepatica. For this, you should tell me the answer. Otherwise, it will become monotonous class. Liver fluke, what should I give? Come on, guys. Whatever you know, just message me. Very good, Shri, very good. The name is triclabendazole. Triclabendazole. So this is the chart. So when you read microbiology, I think you have revised this again. So that is about antimicrobial drugs. I hope I have made this topic clear for you. Remember the treatment of HIV, malaria, TB. TB treatment would have been asked in medicine, PSM also. Then malaria, I told you, leprosy, all these things should be read. Right. So how was the revision of antimicrobials? Just put a thumbs up or put your comments. Then we'll move on to the next topic, endocrine. So before I enter, I want your messages. Please message me. Okay, I think now I am visible. So let us move on to the next one. Thanks for your nice messages here. Okay, so my purpose is to make pharma easy for you. So let us go for endocrine pharma. So whenever I think of endocrine pharma, diabetes comes to my mind. Every year, diabetes drugs are asked. So let's move on to the next question, a tricky one. 44-year-old patient has type 2 diabetes. Now, please understand he has allergy to sulfa. His family has a history of medullary carcinoma of thyroid, bladder cancer. He is already on metformin. The glucose and HbA1c are not under control. What drug will you add? So, patient is already on metformin. He is allergic to sulfa. So, any sulfa drug is available in diabetes. Yes, the sulfonylureas. So, glimepiride cannot be used. Medullary carcinoma of thyroid, glutides cannot be used because they are GLP-1 agonist, which can increase the medullary carcinoma of thyroid. Bladder cancer, I cannot use pioglitazone. So what is remaining for this patient? I can give linagliptin. So the purpose of this MCQ is to make you aware some of the adverse effect of the diabetic drugs. And let us go with that. Now, which anti-diabetic drug cause sodium water retention, fracture in females, and bladder cancer? Just now we discussed. The name is pioglitazone. Medullary carcinoma of medullary carcinoma of thyroid risk is increased by the GLP-1 agonist. GLP-1 agonist. Now, the glucosuria, urinary tract infection, genital mycotic infection, Fournier's gangrene, fractures, lower limb amputation risk, all these have been tested already in the exam. What are these drugs? They are SGLT2 inhibitors and they end with gliflozins. Remember, one question sure shot will come from gliflozins asking their adverse effect. Glucosuria, UTI. When glucose comes so much, bacteria will grow, mycotic infections can happen, Fournier's gangrene can happen. Remember, above this line, they are common adverse effect. Below this line, these are rare adverse effect. Now, what is the anti-diabetic drug cause? Hypoglycemia. 100% the insulin will produce that. Sulfonylureas will produce that, like glimepiride, gliclazide, and the meglitinides will produce hypoglycemia mainly. Meglitinides like repaglinide, nataglinide. Sir, if they cause hypoglycemia, then what about other drugs? Suppose this is a normal glucose. What other drugs will do? They bring the glucose to normal. They don't bring it down. But insulin will bring it down and cause hypoglycemia. Okay, sir. Now, what drug can cause allergy? Mainly, they are sulfonylureas. What drug can cause dilution hyponatremia, hepatotoxicity, and cholestatic jaundice? Not required. The name is called chlorpropamide. It's an old sulfonylurea drug, not asked nowadays. Lactic acidosis, B12 deficiency, contraindicated renal failure. What drug comes to your mind? Tell me. This is for you. Tell me what drug causes lactic acidosis, B12 deficiency, and contraindicated in renal failure patients. 100% one of the best drug, metformin. Yes, very good. We can add diarrhea too. Recently one question came. Severe diarrhea is done by metformin, GAT upset. Now the next question is weight neutral drugs in diabetes, weight loss. Remember the gliptins. Now before I come to this, I'll come to that later. First let us identify the drugs here. Now there are plenty of drugs in diabetes and we forget them. Remember, if the drugs end with gliptins, they are DPP4 inhibitors. Gliptins. Any drug starting with glimepiride, gliclazide, they are sulfonylureas. And what is the mechanism? They inhibit ATP sensitive potassium channel. I'm not writing in full because it's a revision class, not a regular class. Any drug ending with glenide, they are meglitinides. Repaglinide, nataglinide, they also have the same mechanism. Any drug ending with gliflozin, they are SGLT2 inhibitors. Any drug ending with Bose, Oglibose, acarbose, they are alpha glucosidase inhibitors. Now you should tell me this. Any drug ending with glutide or natide, what are they? What are they? If a drug ends with glutide, liraglutide, exenatide, what are they? PPR alpha gamma agonist is pioglitazone. Now recently there is a drug which can be alpha and gamma agonist. The name is called saroglitazar. Yes, very good. These are GLP-1 agonist. Pramlintide, it's amylin receptor agonist. Tell me what is the drug which inhibit hepatic gluconeogenesis and decrease hepatic glucose uptake? Decreases the hepatic glucose output. What is the drug name? Tell me. Inhibit hepatic gluconeogenesis. The name, yes guys, you know it. Metformin. How can you forget metformin? Remember, out of all these drugs, remember these three drugs, pioglitazone, metformin, saroglitazar, these are also called as insulin sensitizers. Insulin sensitizers, very, very good drugs. So let me repeat again. Repeat with me. Gliptins, DP4 inhibitors. If they start with gli, they are sulfonylureas, glinide, glitinides. At least remember gliflozins, glutide and natide are GLP-1 agonist. PPR gamma is pioglitazone. Inhibit gluconeogenesis metformin. At least you should remember this much. Sir, why in detail diabetes? Diabetes is a topic from pediatrics, a major topic from medicine, and a major topic from pharma, and it's a major disease in our country. So obviously there will questions come, particularly in SGLT2 inhibitors. So let me tell you the weight parameters. Weight neutral drugs are DPP4 inhibitors and metformin. So recent guidelines are telling metformin as weight neutral and some weight loss. Insulin sensitizer will not cause hypoglycemia. That is why I made a list. What drug cause hypoglycemia? Only these three will do that. Then weight loss. Weight loss are the new drugs. The new drugs are gliflozins. Then the pramlintide. And the drugs ending with glutides. They can cause weight loss. Weight gain, all old drugs. Insulin is a old drug. Sulfonylurea, meglitinide, and then the pioglitazone, they all cause weight gain. I think there is a lag. Okay. Heights and tides, no, not like that. Nimra, please remember this. These are the only three drugs which cause hypoglycemia. Other drugs will cause hypoglycemia if you give them with insulin. Otherwise, as such, they are not going to increase glucose so much. Right. So the next one is, tell me the specialty of these drugs. Which is a drug which is GLP-1 and GAP? What drugs increase GLP-1 and GAP levels? They are DPP4 inhibitors. So if I inhibit this enzyme, the GLP-1 and GAP levels increases. What drugs are approved for obesity? I have told you this and you should answer this. What diabetic drugs are approved for obesity? Please answer that. DPP4 inhibitor, safe in renal failure, plenty of times asked. The name is linagliptin. So renal failure, lina ko lena linagliptin. What is the SGLT2 inhibitor used in renal failure patient? even GFR is 20 ml. So remember, empagliflozin can be used. What is a GLP-2? Remember, it's not one. Used in short bowel disease called teduglutide. This is also being tested in one of the NEETPG. Now recently GLP-1 and GAP agonist is available. The name is called tirzepatide. The name is tirzepatide. So for obesity, liraglutide, semaglutide and tirzepatide. So let me repeat again. Liraglutide, semaglutide and tirzepatide are used. Okay. Now coming to diabetic kidney disease, suppose a patient has diabetic kidney disease, is diabetic. Obviously diabetic people are prone for kidney disease. So the first preferred are AC inhibitor and ARBs because they are known to decrease microalbuminuria. So the second drugs which are also nowadays good for this is SGLT2 inhibitors. They are gliflozin, and we have another drug called finerenone, which is a aldosterone antagonist. So these are the drugs for diabetic kidney disease which can be tested in your exams. Right. So remember, SGLT2 inhibitors is a favorite for examiner. Now when they started discovering, they were for diabetes. Now they are used in CHF because they reduce hospitalization and mortality. I told you that. They also decrease the coronary heart disease, and they also are useful in kidney disease. So they are helpful in heart also, kidney also. Please remember the gliflozins are famous for this. That is why plenty of questions come for gliflozin adverse effect, gliflozin uses in heart failure and kidney diseases. So please read these gliflozins carefully. Right, now let us move on to the next one. SERM, selective estrogen receptor modulator, used in breast cancer, and it increases endometrial cancer risk. The name is called tamoxifen. What is the serum used in osteoporosis? The name is called raloxifene. I think Crystal, it will be available. So if you people are hungry, you can take a break. It will be recorded, so no problem. What is the SERD? That is selective estrogen receptor downregulator used in breast cancer. The name is called fulvestrant. Fulvestrant. Then coming to aromatase inhibitors used in breast cancer, the name are letrozole. So they end with ozole. One more is anastrozole. Then the mestane drugs, exemestane and formestane. What is the SPRM? That means selective progesterone receptor modulator used as emergency contraceptive up to 120 hours. Usually emergency contraception is given up to 72 hours. Example, the combined OCPs, mifepristone, and up to 120 hours, the drug that is used is called ulipristal. So in one of the NEETPG, they asked dose also. Sometimes to make the paper tough, they ask the dose also. Usually they don't ask, but they have asked. Suppose a patient comes after 5 days of intercourse, then the next option will be IUD, intrauterine device. So coming to the thyroid. Drug of choice for hyperthyroidism in first trimester is PTU, propyltyrosol. Drug of choice for hyperthyroidism in second and third is carbimazole. If it is not there, you can go for methimazole. Graves disease also, the drug of choice is carbimazole. Now antithyroid drug which are faster acting, they are iodides. For example, sodium iodide, then potassium iodide and Lugol's iodine. These are faster acting. So they were also used preoperatively. Why they are used preoperatively? These iodides, they decrease the bleeding during surgery. They make the gland firm and less vascular. What is antithyroid drug can cause permanent hypothyroidism, that is called radioactive iodine 131. So it is called radioactive iodine 131, which will cause permanent hypothyroidism. So it should not be used in pregnant, lactation and children because it's a radioactive material. Right, so these are the things. Now the next question is longest acting phosphodiesterase 5 inhibitor. Can you guess the answer? Now remember, phosphodiesterase inhibition will lead to increase in cyclic GMP levels. Take a guess. Remember, phosphodiesterase inhibitors end with phil. I will give an example, sildenafil. Tell me what is the longest acting. Yes, the name is tadalafil. I told you, tal, T, they are longer acting. Drug used in hyperprolactinemia. Remember, hyperprolactinemia can lead to galactoria. And galactoria can lead to infertility. Hyperprolactinemia can also lead to infertility. So what is the drug commonly used? The commonly used drug is bromocriptine. And one more drug that is commonly used is cabergoline. So the preferred one among the bromocriptine and cabergoline is for all the patients cabergoline because it is longer acting and lesser adverse effect compared to bromocriptine. So you can prefer giving cabergoline. If both are given in the option, my perspective is go for cabergoline. Drug of choice for osteoporosis, any osteoporosis, whether it is postmenopausal, due to aging senile, or due to steroid, the drugs are bisphosphonates. How do they end with? They end with dronate. Dronate means zolendronate, palmidronate. So the mechanism is they inhibit osteoclast activation. Osteoclast activation. Even in pregnant women, there is a debate whether to give bromocriptine, cabergoline. There also you can start with cabergoline only. Then teriparatide. Remember, it's a recombinant parathormone. It's a bone forming agent. That means it stimulates osteoblast. It's an osteoblast stimulator. And what is the monoclonal antibody against rank ligand used in osteoporosis? Osumab. Yes, KK, avanafil is the fastest acting. So remember, the phosphodiesterase 5 inhibitors can be remembered like this. You know PSVT, these are ASVT. A for avanafil, sildenafil, vardenafil, and tadalafil. Okay, so avanafil has faster action and short duration of action. Longer is tadalafil. Now, sildenafil and tadalafil are also used to manage pulmonary hypertension. Sildenafil and tadalafil are also used to manage pulmonary hypertension. Yes, bisphosphonate, remember bisphosphonate, they can cause osteonecrosis of jawbone, they can cause esophagitis, gastritis. But if you are using bisphosphonate for more than 5 years, there is a risk of intertrochanteric fractures. So please keep that. See, QT prolongation, vardenafil, some cases have been reported, but not so much confirmed as IL. Drug of choice for Bell's palsy, will I give acyclovir or prednisolone? If both are given, what will you choose, guys? Somebody had Bell's palsy, what do you use? Steroids are contraindicated in ileocecal TB, Kaposi sarcoma, peptic ulcer, true. So steroids should not be used in ileocecal TB because they can cause intestinal perforation. Kaposi sarcoma is a cancer in HIV and where there is already immunosuppression. If I use steroid, they also suppress immunity. Steroids decrease prostaglandin, so they can cause gastritis and worsen peptic ulcer. So remember, the drug of choice for Bell's palsy is prednisolone. If both are given, go for prednisolone. Acyclovir is additional drug, but most important is steroids for Bell's palsy. Long-term use of oral steroid. Patient develop blurring of vision and the reason is, now when we give steroid systemically, what is the problem? Will you get cataract or glaucoma? Tell me. Will you get cataract or glaucoma when you give oral steroids? Remember, oral steroid will cause cataract. So remember the simple mnemonic GTCS. So glaucoma if you give topical steroid, cataract if you give systemic steroids. Right. I will give PDF, don't worry, that's what I told you. So after this, in the YouTube session only, there is a link for Telegram group, Instagram group. You can contact me from anywhere, and we have a Telegram group also. There you can download this PDF. Otherwise, how can I give it? I thought CTGS. Okay. GTCS. Now, whatever, please remember that. Now, preterm labor. Again, this is an OBG question. Preterm labor to make the lung mature. Dexamethasone, remember 4th letter in ABCD. So we give 4 doses, and 12th hourly we give up to 36 hours it takes. So 4 doses we have to give, and the dose is 6 milligram. Betamethasone 2 doses, 12 milligram, give at the timing of 24 hours apart. So this is preterm labor, and plenty of times it has been tested. So last is identify the wrong match. Tadalafil is used in pulmonary hypertension, erectile dysfunction. True. Finasteride. What is finasteride? It's a 5-alpha reductase inhibitor approved in male pattern baldness and BPH. True. Now, why do I use finasteride in BPH? In BPH, it reduces the size of the prostate. Flutamide is an androgen receptor blocker used in prostate cancer. True. Phentolamine is used in delayed ejaculation. False. Phentolamine is used in erectile dysfunction, not in delayed ejaculation. It is used in erectile dysfunction. Okay, so the answer will be D. Okay, so anti-cancer drug. So what important aspect I should remember in anti-cancer drug? Let me understand here. When you read anti-cancer drug, I know there are plenty of things and you're trying to forget, but what is the thing what they are asking in the exam? You should be knowing that. You should never miss these things. In anti-cancer drug, the most important thing they ask you is, what is the common adverse effect of anti-cancer drugs? So whenever we give anti-cancer drug, they cause bone marrow suppression. So patient will develop leukopenia and granulocytopenia. There is decrease in the WBC count. So what do we give there? We give there the GM-CSF analog, and the name is sargramostim. Sargramostim. So remember, granulocyte, monocyte stimulator. Or we can use G-CSF analog. The name is filgrastim. It's a granulocyte stimulator. Thrombocytopenia, we use interleukin 11 analog. The name is oprelvakin. Read it as 11. Kin means interleukin. Anemia, we use erythropoietin group called E-poietin. If you add darbe, it becomes darbepoietin. So recently they are tested interleukin 11, oprelvakin recently. Then the early CANV, within 24 hours, we use 5-HT3 antagonist, and remember they end with cetron, ondansetron, granisetron, like that. Late CANV, we use neurokinin 1 blockers, and they end with pitant, apripitant, natopitant, like that. What is the best combination for CANV? Best combination is give 5-HT3 blocker also, that is cetron, give pitant, and with that you add a steroid, that is dexamethasone. So that is the best combination you can give for the CANV. Okay. Now coming to the other adverse effect, diarrhea due to anti-cancer drugs. Yes, the best drug is loperamide. This is also being tested. It's an opioid. Radiosensitization, if happens, there is a radioprotector drug. Can you tell me what is a radioprotector drug you know? Yes, tell me. If there is hyperuricemia, tumor lysis syndrome, the fastest acting will be rasburicase. If that is not there in the option, how do you bring down the uric acid? We use allopurinol in this case. But the faster acting is rasburicase. The radioprotective drug name is amifostine. Amifostine. Now there may be hypercalcemia of malignancy. How do I bring down calcium? I use calcitonin, which will work faster. If it is not there, I use loop diuretic called furosemide. If not, then the last one is bisphosphonate, that is dronates. We use bisphosphonate, that is dronate. Even cancer-induced thrombosis was asked, what do you use? We use low molecular weight heparin. Example, enoxaparin. So parins can be used for here. Cancer-induced thrombosis. So please understand, in anti-cancer, most of the times what we do is we never touch anti-cancer, only seeing so many drugs are there. At least minimum you do this. And you check any exam, this table, what I have told you, this table, one or the other question have come. 2018 they had asked early, what do you use? 2020 they had asked thrombocytopenia, what do you use? Recently they had asked best combination. Then 2017 they had asked cancer-induced thrombosis, what do you use? Diarrhea, what do you use? Everything has been tested. So this table is very, very important. Now, certain adverse effect of anti-cancer drug causing cardiotoxicity, the name is trastuzumab and the anthracyclines like daunorubicin, doxorubicin. Drug causing hemorrhagic cystitis, can you tell me the name? Cyclophosphamide and prevented with mesna. Hairy cell leukemia, the drug of choice is cladribine. Anti-cancer drug which causes thymidine-less cancer cell death. Now thymidine belongs to pyrimidine. Now tell me pyrimidine antagonist used as anti-cancer drugs. The name is 5-fluorouracil. 5-fluorouracil. So lab monitoring when methotrexate is used is LFT because it is toxic to the liver. Anti-cancer drug inhibiting dihydrofolate reductase is methotrexate. Radiation recall syndrome is done by anthracyclines like rubicins. Daunorubicin, doxorubicin, they are called anthracyclines. Drug of choice for CML is imatinib. So basically this much information should be known. A patient with stomach cancer also had heart failure. So which drug will you avoid? Obviously, the rubicin should be avoided because they are cardiotoxic. Bleomycin can cause a special adverse effect, that is flagellate dermatitis. This is also been tested. Flagellate dermatitis. 5-fluorouracil can cause a syndrome called hand-foot syndrome. And one more drug that produced this and repeatedly tested is capecitabine. So we have a chemoman here. Remember, chemoman, the C and C ototoxicity and C and C nephrotoxicity is by platinum. The V peripheral neuropathy is done by vincristine, that is Vinc alkalides. The lung, that is lung toxicity is done by B bleomycin and busulfan. D and T, that is rubicins, daunorubicin, doxorubicin, trastuzumab can cause cardiotoxicity. Cyclophosphamide can cause CY hemorrhagic cystitis. Now they can also ask you, can we prevent the cardiotoxicity done by doxorubicin? Can we prevent? Yes, we have a drug to prevent that. The name of the drug is called dexrazoxane. Now, can I prevent hemorrhagic cystitis? The name is called mesna. These have been tested. Yes, cytarabine causes cerebral ataxia. We can tell plenty of adverse effect. If you give me, I will take 3-4 hours anti-cancer only. But At the end of the day, how much you remember, how much you reproduce, and how much are asked in the exam is important. Because the simple concept is, I should know methotrexate mechanism. You don't know other, no problem. You don't know doxorubicin mechanism, they are not worried. Whether you know the mechanism of action of methotrexate, yes. Whether you know when we give methotrexate what should be monitored. Whether you know the antidote for methotrexate toxicity, yes, we know folinic acid, also called as citrovorum factor. So these are the things what we need to understand. Okay, yes. Now certain monoclonal antibodies, I'm telling you minimum this much you should remember. If you have read everything, 100% okay. But if you have not read anything, you don't want to touch the topic, at least remember this. The epidermal growth factor is blocked by cetuximab and used in colon cancer, head and neck cancer. Trastuzumab is a HER2 new blocker used in breast cancer. Vascular endothelial growth factor, bevacizumab, a very favorite for the ophthalmology. It is used in colorectal cancer and retinopathy. Then moving on to the small molecule inhibitors, the BCR-ABL tyrosine kinase inhibitor, imatinib, dasatinib, nilotinib, they are used in CML. The HER2 new inhibitor, lapatinib, neratinib, they are used in metastatic breast cancer. Right. Now come to the next part, the blood pharma. Blood pharma. Again, blood pharma is a small topic, but plenty of questions come from this. Okay, let us finish these things. A patient with breathlessness, so a patient with breathlessness, chest pain and irregular heartbeat. Known case of mitral stenosis, echo is normal, shows no thrombi. What is the best way to prevent thrombosis in this patient? So patient is having breathlessness, chest pain, irregular heartbeat, atrial fibrillation, and we don't want the patient to develop a clot. So we want to give prophylaxis, and patient is having mitral stenosis. Then what is the drug used? Yes, the drug used is warfarin. The drug used is warfarin. Suppose the patient didn't have mitral stenosis, then what is your answer? Your answer would have been dabigatran or apixaban. Now coming to this, a very important chart. Now we will discuss mechanism, whether they require a routine lab monitoring or they have antidote. Now anything ending with hexaban, they are direct 10A inhibitor. Do they require lab monitoring? No. Do they have an antidote? Yes. So remember ANDE. When you are in 10th standard, you got a ANDE. It is called andexanet alpha. Dabigatran is direct thrombin inhibitor. Do you require lab monitoring? No. What is the antidote? Dabigatran. It is a MAB. Can you tell me the name? Remember as Daru. It is Daru Cizumab. So whenever you get Daru, Dabigatran. Daru, Dabi. Warfarin, it's a vitamin K antagonist. Lab monitoring is INR. The antidote is vitamin K. Unfractioned heparin, it's not directly acting, it activates antithrombin 3 and then inhibit the factor 2A and 10A equally. The monitoring is done by APTT and the antidote name is protamine. Anything ending with parin, they are low molecular weight heparin. They also activate antithrombin 3 and they inhibit 10A more than 2A. No routine lab monitoring is required. The antidote is protamine. anything ending with parin ux, remember it is telling you I am something related to heparin, but I inhibit only X. So this will also activate antithrombin 3 and it inhibits 10A only. No 10A only. No need of lab monitoring, no antidote for this. Then argotropin and lepirudin, these are direct thrombin inhibitors. They have lab monitoring, that is APTT and PT, and they have no antidote. Remember the first three drugs what you have written, they are all oral drugs. The next whatever you have written, they are all drugs given as injections. Now the rivaroxaban, dabigatran, they are also called as Novax because they are novel, means new, novel oral anticoagulants. So in this table, we have finalized the mechanism, lab monitoring and antidote at one places. So please revise it. Okay. Now again antiplatelet. So we have done the match the following. So number one, low dose aspirin. How does it work? It inhibits COX and reduces thromboxane synthesis. Number two, clopidogrel and prasugrel. Anything ending with grel, they inhibit P2Y12. But remember the inhibition is irreversible, so this is the answer. Any drug ending with grel R, they are also P2Y12 antagonists, but they are reversible. Remember the 3 is here. Number 4, the MABs, tides, bands, they are all GP2B3 antagonist, so it is correctly matched. Streptokinase, urokinase, altiplase, or anything ending with ASC in pharma, they are enzymes. And these are fibrinolytic drugs. That means they cause lysis of clot. Number 6, tranexamic acid, epsilon aminocaproic acid, they are antifibrinolytic. They stop the fibrosis. So this is the table. So one of the questions they will ask you is, if there is fibrinolytic overdose, that is streptokinase overdose, what do you give? We give antifibrinolytic, that is tranexamic acid and ECA. And very good, I'm reading your name as Nirma only. This is Nimra. The grels are also prodrugs. Clopidogrel and prasugrel also are prodrugs. Remember, all these antiplatelet drugs, anticoagulant, they increase the risk of bleeding. Now remember, if you want to give for stroke prophylaxis, stroke to prevent stroke prophylaxis, there are only 3 drugs approved: aspirin, clopidogrel, and D for dipyridamole. Stroke prophylaxis, 3 drugs are used. Number 1, aspirin, clopidogrel, and dipyridamole. Can I give prasugrel in stroke prophylaxis? No, because they have increased the risk of hemorrhage in the brain. So we don't use it. Yes, somebody was asking drug of choice for heparin-induced thrombocytopenia. The first choice will be argatroban. That is the first one. If that is not there, again go for fondaparinux. So simply remember, first go for the direct thrombin inhibitors. If they are not available, go for the heparin derivative fondaparinux. Patient came with warfarin induced bleeding. What is the next step? Dabigatran is oral drug, so it's an emergency. HIT is an emergency. Oral drug cannot be used in emergency. Patient came with warfarin induced bleeding. What is the next step? It's also an emergency. The next step is to give 4-factor prothrombin complex. Prothrombin complex. Right? If it is not available, you can give fresh frozen plasma. Then when is the answer vitamin K? The answer becomes vitamin K only if they ask you antidote. Patient is already bleeding. If you give vitamin K takes 1 day to start working. They would have bled. So if I give these factors, mainly they contain two. Just tell me, what are the factors? 2, 7, 9, 10 factors. It's already activated, I can give them. Pregnant woman with dyslipidemia, which anti-dyslipidemia drugs are safe? So pregnant woman has dyslipidemia, which one are safer? Remember, the names are bile acid binding resins. Sir, how do I know them in the exam? They all start with cole. Not chole bhature, this is cole. Cholesevelam, cholestiramine, cholestipol. If they are cole, then you can give it in pregnant women because they are not absorbed, so they are safer. Now guess the drug in dyslipidemia. The pointers to understand is they are PPR alpha agonist. They can cause myopathy, but special adverse effect is they can cause gallstone. What are the drugs I am talking about? HMG-CoA reductase inhibitors, they can cause myopathy, risk of diabetes, impaired liver enzymes. They are vastatins. So you can have rosuvastatin, atorvastatin, all those things. Now these are fibrates. Now fibrates can increase risk of gallstone. Please remember gallstone, fibrates. High intensity statins, these are the statins which can bring down the LDL to less than 55%. They can decrease by 55%. And there are two statins. The name is atorvastatin and rosuvastatin. The dose is 40 to 80 milligram. And rosuvastatin 20 to 40 milligram. And they are used in IMI cases. Now, this is a favorite nowadays, PCSK9 inhibitors. The names are MABs, alirocumab, and evolocumab. Yes, these are the one. Maximum LDL is reduced by statins. Triglycerides are reduced by maximally by fibrates. And maximum HDL is increased by a vitamin called niacin. So this is about the drugs for dyslipidemia. Please concentrate on PCSK9 inhibitors. Plenty of times it has been tested. Okay, so poison and overdose. I told you fibrinolytic overdose. We use ECA or tranexamic acid. Acute iron toxicity. Acute, if it is given, we use deferoxamine. Deferoxamine can be given IV or IM. Now, if it is chronic iron poisoning, then we use oral drug. Remember, the iron poisoning, the drugs start with defer. They defer the iron. Sir, how do I know which is for chronic? Remember, if it ends with amine, amine is for acute. Remember, amine is for acute. If it doesn't end with amine, that means they are for chronic. So how do I know the drug? I will repeat again. They start with defer. And if they end with amine, they are for emergency. If they start with defer and don't end with amine, they are for chronic condition. That's it. So the last one is again paracetamol. Let us quickly go. The antidote is N-acetylcysteine. Magnesium sulfate. What is the antidote? Let me give 1 and 1 for this. Magnesium toxicity. Second, what is the antidote for magnesium? Yes. Third, isoniazid. What is the antidote? B6. Correct. Methotrexate. What is the antidote? Leucovorin, folinic acid, and cytovorum factor. Number 5. Sulfonylurea induced hypoglycemia, use octreotide. That is also correct. But magnesium sulfate toxicity, we don't give vitamin K. Then what is the answer, guys? What do I give for magnesium toxicity? I give calcium gluconate. So all are matched. All are matched. So remember 2 for 2, 3 for 3. Like that. So why I didn't do antidote at one place? You may forget that. And the last topic, CNS pharma. CNS Pharma, I think another. Okay, we'll finish that. That's the only thing remaining, guys. Shall we continue? I'm also tired. I also feel like stopping it, but yes, we require ischial tuberosity. Okay, no break. Because to become a doctor, we require two things: patience and patience. Okay. Kana खाइए. Okay. See, being a doctor, I have done night duties and all, where we have not slept properly also. And खाने का क्या है? No, you can't judge somebody's position. You should be in their position to judge what they will be doing later. Okay. I mean, with this much of energy, we're talking for 4 to 5 hours, 6 hours. Do you think uske baad we can continue with the partying? No. Okay, no problem. We'll move on. So next question is, a 25-year-old female, increased heart rate, sweating, excessive worry from last 2 hours, acute anxiety was diagnosed and was started on a drug which can act rapidly. Which drug was used? Remember, it's a case of, it's okay, take it lighter. So it's a case of acute anxiety. Now, any acute CNS excitation condition, we use benzodiazepine. So here we use lorazepam. Now, buspirone, vilazodone, escitalopram. Remember, buspirone, escitalopram, they are used for chronic anxiety. They will not work immediately. They are also used in general anxiety disorder. But if it is an emergency, acute anxiety, then benzodiazepines are the drug of choice. The next question is, a 65-year-old patient presented to the hospital with complaints of tremors, bradykinesia, and rigidity. That means Parkinson's disease. He was started on a MAO-B inhibitor. What is the MAO-B inhibitor here? Now, entacapone. Remember, anything ending with capone, they are COMT inhibitors. Remember, capone, C for COMT inhibitor. Anything ending with gelin, selagelin, rasagelin, they are MAO-B inhibitors. Recently, there is one more MAO-B inhibitor. The name is called safinamide. Levodopa is given with carbidopa. We all know that. And pramipexole, ropinirole, and rotigotin. These all are non-ergot D2 agonist. So all these drugs are used in Parkinson's disease. COMT inhibitors, MAO-B inhibitors, levodopa, pramipexole, ropinirole, rotigotin, all are used in Parkinson's disease. Now, another problem is alcohol. Which of the following drug used as aversion therapy in chronic alcoholics? The chronic alcoholics, the aversion therapy is mainly by disulfiram. Disulfiram inhibits an enzyme called aldehyde dehydrogenase. So when you inhibit this enzyme, the acetaldehyde level increases. Patient will feel nausea, vomiting, headache, chest tightness, palpitations. So that's why it is aversion therapy. Naltrexone is also used in alcoholics. Naltrexone will decrease the craving in alcohol. Now, lofexidine is an alpha-2 agonist. We have discussed this drug earlier. It is used to decrease opioid withdrawal symptoms. Opioid withdrawal symptoms. Naltrexone is an opioid antagonist. It is used to decrease relapse in opioid addicts. In opioid addicts. And varenicline Varenicline is a nicotinic partial agonist. It is used in smoking cessation. And smoking cessation, we have varenicline, one drug. Then there is a drug called bupropion, another drug. And number 3, we have nicotine replacement therapy. Nicotine replacement therapy. That means we can give a patch, we can give a lozenges and all these things. Now tell me, out of all these 3, which is the most effective treatment for smoking cessation? I am waiting for your answers. So please remember, they will ask you the de-addiction program of alcohol, opioid, and smoking. That's why this slide covers everything. This slide covers everything here. The most effective therapy for smoking cessation is varenicline. Write down varenicline. That is the most effective therapy. Now moving on to the epilepsy. So in epilepsy, they keep on asking the drug of choices for epilepsy. Now let me start with the generalized seizures. So remember, for all these seizures, the drug of choice is valproate. If valproate is not given, then I can go for another drug by the name lamotrigine. Let's keep this in simple things. Now suppose the patient has focal or partial seizures. The drug of choice is carbamazepine. If that is not there, you can go for again lamotrigine. Now coming to absence seizure, this is one of the frequently asked doubt for me in everywhere. Sir, absence seizure, should I give valproate? Remember, if they have given child and absence seizure, obviously I don't want to give valproate. There is no age limit, less than 2 years, more than 2 years. Any child having absence seizure, and when I have a very good drug like ethosuximide, I will 100% give it. I don't want to give valproate because it is hepatotoxic. Trigeminal neuralgia, the drug of choice is carbamazepine. Other types of seizures, febrile seizures. Febrile seizures, nowadays the preferred one is intranasal midazolam. So we give into the nose midazolam. Earlier we used to give rectal diazepam. So which one is easier to give? Intranasal is easier to give, so that is why it is preferred now. Infantile spasm, also called as West syndrome or Hips arrhythmia. The drug of choice is ACTH, adrenocorticotropic hormone. Suppose infantile spasm with tuberous sclerosis, then we use a drug called vigabatrin. Now vigabatrin is one of the beautiful drug for infantile spasm, but we don't use it. The reason is, the problem is with vigabatrin is it causes vision impairment, and an infant cannot tell the vision impairment. Eclampsia, the drug of choice we have discussed already is magnesium sulfate. Any patient comes with status epilepticus, the initial drug what we give is lorazepam. If that is not in the option, we give diazepam. There are plenty of guidelines for status epilepticus, but whatever the guidelines, the first thing what we start is either lorazepam or diazepam. If it is not controlled, we have various options. You can give phenytoin, phenobarbital, you can give valproate, you can also use levetiracetam in these patients. That is the later. And the last step is general anesthesia. That's it. So this is what is more important in anti-epileptics, the drug of choices. Now moving on to the next one. Phenytoin and carbamazepine are not used in myoclonic seizure and absence seizures. What do you think? True. It's a true statement. Phenytoin and carbamazepine are not at all used in these two seizures because they increase the seizures. What are anti-epileptics used in neuropathic pain? Carbamazepine is used. Then we use pregabalin and gabapentin. So these are for neuropathic pains. Anti-epileptic drug causing Stevenson syndrome, mostly that is done by lamotrigine, followed by phenytoin and carbamazepine. These are going to cause the rashes, Stevenson syndrome. Now the next question is, does anti-epileptic drug require therapeutic drug monitoring? Yes, they require it. What is the anti-epileptic? They are used in bipolar disorder also. Yes, valproate is used. Carbamazepine is used. Even lamotrigine is used in bipolar disorder. Right, sir. Now guess the anti-epileptic drug. Many a times you would have read anti-epileptic, so many adverse effects. Now it's the time to guess. Now neural tube defect, increased ammonia and hepatotoxicity, curling of hair. What comes to your mind? The drug is valproate. Hepatotoxicity, hyponatremia, allergy, thrombocytopenia. What comes to your mind is carbamazepine. Remember, carbamazepine is hepatotoxicity, hyponatremia. So the question was asked recently, can we combine these two drugs, valproate and carbamazepine? Can we combine them? No, because both are toxic to the liver. Hepatotoxicity, we don't give them. Any drug having gum hyperplasia, hirsutism and fetal hydantoin syndrome, megaloblastic anemia, it will be phenytoin. It will be phenytoin. Sahil, the dose range for valproate and carbamazepine, they are important for INACT pattern of exams, not for this. If you want, I can give it later. Okay. Now, another question that will be asked in the exam is the extrapyramidal symptoms of haloperidol. Remember, haloperidol is an antipsychotic. It is a D2 blocker. It is called as typical antipsychotics. Typical antipsychotic meaning they block D2. Now, when you block D2, the problem that happens is extrapyramidal symptom. The first thing that happens is acute dystonia or oculogyric crisis. So the treatment is with benzhexol. Remember, benzhexol is also called by a name trihexyphenidyl. Suppose this is not there, you can use a drug by the name promethazine. Promethazine. Can you tell me an antiemetic which can also cause dystonia? Can you tell me the name? An antiemetic causing dystonia. Drug-induced Parkinson's disease is also treated with the same drugs. Akathisia means patient cannot sit at one place. So the drug what we use is propranolol. It's a beta blocker. If it is not there, then the next option is benztropine. If it is not there, then the last option is benzodiazepines. Then the last option is benzodiazepines. Now I will ask you a question. Suppose patient has akathisia and she is also asthmatic, then will you give propranolol or will you give benztropine? Suppose patient has akathisia and asthma also, will you give propranolol or benztropine? That is the next level of questions. Neural malignant syndrome, you see the high temperature, myoglobinemia, muscle rigidity. Then what I use is a drug called dantrolene sodium. Now dantrolene inhibits a receptor called ryanodine receptor 1 and inhibit the calcium release and inhibit the muscle contraction. So the antidote or drug of choice is dantrolene. Suppose the patient is having bronchial asthma, then I cannot give propranolol. So the next option will be benztropine, and most of you are told that. Very good. Tardive dyskinesia is the late complication. See, remember these complications we have arranged according to the timeline. Earlier is dystonia and the late one is dyskinesia. Dyskinesia we use VMAT 2 inhibitors and they all end with benazine. For example, valbenazine, tetrabenazine. So benazine drugs are used for dyskinesia. So this is a question from psychiatry, it's a question from pharmacology, it's a question from medicine. Every year or the other year, this question comes. the extrapyramidal symptoms due to typical antipsychotics and how do you manage that. And asked which antibiotic can cause dystonia, that is metoclopramide. Coming to the facts, Risperidone is FDA approved for schizophrenia, correct. Can be used in mania also, yes. BPD, yes. Hyperactivity in autistic disorder, true. Remember, any drug usually ending with iodine, or if they end with apine, like clozapine, olanzapine, they are atypical antipsychotics. Somebody were asking how to remember. If they end with iodine or apine, they are atypical antipsychotics. Now, atypical antipsychotics, they don't cause extrapyramidal symptom so much. But there is one atypical antipsychotic. If you give it at high dose, it can cause extrapyramidal symptom. The name is, anybody? Risperidone. Yes, Nirmal, you are also, Nimra, you are also right. VMAT2 inhibitors are also using Huntington's chorea. Aripiprazole, I told you don't confuse with pantoprazole, is an atypical antipsychotics. It has also partial D2 agonism. True or false? True. Remember, anything ending with iodine, apine, aripiprazole, they are all atypical antipsychotics. Remember, atypical, they mainly block 5-HT2 receptor more than D2 receptor. What is the advantage? Less extrapyramidal symptom. But what is the disadvantage of atypical antipsychotics? They can cause metabolic syndrome. Right. So can you guess the drug? Can you guess the drug? Yes, Nimra, you are right. The least metabolic adverse effect is seen with aripiprazole and also a drug called ziprasidone. So a drug, then they are eating the cheese, wine, the BP has gone up. You can see the BP 203. So this is a reaction called cheese reaction. So any person who is on MAO inhibitors, if they eat cheese or drink wine, the BP shoots up. So the drug is MAO inhibitors. And then the reaction is cheese reaction. And it's a hypertensive condition. You can use phentolamine or labetalol to bring down the BP. A drug used in depression acts by inhibiting both serotonin and noradrenaline reuptake, that is SNRI. What is the drug SNRI here? So remember, venlafaxine is a SNRI, venlafaxine, duloxetine, and milnacipran. These are SNRI. So I can give a story for you. When I was in Los Angeles, I faxed in venlafaxine. तो क्या फैक्स किया था मैं? मिलना है, काफ़ी सिप करना है, रैन करना है, मिलना सिप रैन, और दोनों लग्जरी लाइफ देना है, दोनों लग्जरी लाइफ, duloxetine. These are SNRI. Anything ending with oxetine, paroxetine, fluoxetine, duloxetine, these are SSRI. Even escitalopram is an SSRI. So please understand, usually oxetine, citalopram, they are SSRIs. Bupropion is an NDRI. It is used for smoking cessation also. A female developed pain and insect crawling like sensation on legs at night, which is relieved by shaking her legs. Which is the drug of choice for this condition? First of all, tell me, what is the condition we are discussing? Another 3-4 slides are be in the Josh. So this is a condition called restless leg syndrome. So nowadays, the chronic restless leg syndrome, the drug of choice are the pentinoids, gabapentinoids like gabapentin. Earlier, we used to give ropinirole, pramipexole, and all those things. Nowadays, the drug of choice are gabapentins. A 30-year-old male is on drug therapy for psychiatric problem. He complains of urination increased, thirsty. He started getting acne and gained some weight. What is the most likely drug? Obviously, polyuria, polydipsia means diabetes insipidus. And acne and weight gain, it will go for lithium. Lithium can induce diabetes insipidus. So let us check what are the adverse effect and can you guess it? polyuria, Epstein's anomaly, tremors, hypothyroidism, hypercalcemia is done by lithium. Livedo reticularis, ankle edema. Can you guess what drug can cause the livedo reticularis and ankle edema? Guess. Gangrene is done by ergots mainly. Ergots or its derivative. Livedo reticularis is done by amantadine. Amantadine. Metabolic syndrome. I have written what are the metabolic syndrome, but it is done by atypical antipsychotics. And maximum is done by clozapine, olanzapine drugs. If both are given, remember olanzapine is going to cause maximum metabolic syndrome. Least metabolic syndrome is done by aripiprazole and ziprasidone. These are least. Now coming to the next adverse effect, insomnia, anxiety, diarrhea, anorgasmia, delayed ejaculation. What drug comes to your mind? Which CNS drug are going to cause it? Yes, Sahil, you are right. SSRI. Now please note down, this SSRI adverse effect is frequently tested. Which CNS drugs have anticholinergic, antihistamine and alpha blockade property? Which CNS drugs can block histamine, cholinergic and alpha? They are TCAs, tricyclic antidepressant like imipramine, amitriptyline, and also the typical antipsychotics also do that. Priapism, painful erection of penis, is done by trazodone. Now the last one is important. Yes, doxepin has antipruritic property. This one I will be very happy if you tell. Agonocytosis, pylori, myocarditis and seizures. Tell me which drug can do that. And remember, it's a rare adverse of agonocytosis. Yes, very good. You guessed it correct. Clozapine. The name is clozapine. Remember, clozapine is not used in the beginning. It's used for resistant cases. Clozapine, one advantage is it has anti-suicidal effect. Can you tell me one more drug which has anti-suicidal effect? Can you tell me one more drug having anti-suicidal effect? Yes, tell me one more drug. Yes, the name is lithium. So lithium and clozapine, they have anti-suicidal effect. Yes. Coming to dehydration, hyponatremia, fasting, diarrhea increases lithium toxicity. True. Now, how do I know in the case that lithium toxicity has happened? Remember, in the case if they are given coarse tremors, if they are given seizures, if they are given tinnitus, all this point towards the lithium toxicity. If they give fine tremors, that is not a toxicity. Now, lithium is narrow therapeutic index, so we do therapeutic drug monitoring after 5 to 7 days. Why we wait for 5 to 7 days? To achieve steady state. And blood is drawn 10 to 12 hours post dose. Suppose I take 9 a.m. in the morning, I will draw the blood in the 9 p.m. in the night. So it's a true state. Not so much, Sahil. They don't ask so much about agonocytosis monitoring. So they have asked agonocytosis, which drug has caused? Is it a common or rare problem? It's a rare problem. Monitoring is simple. Any agonocytosis, we have to check for the CBC. If CBC is coming down, then we have to take care. That's it. Okay, so that's it from my side. Thank you all. Thank you all. And best wishes for NEETPG. Because it was a request from most of the students to do one revision session, and there were many students of me asking for this session, and I had to do it in one go. And my purpose is to tell you that pharma is easy. Please revise, and this is the Telegram, the green one. This is the Instagram. So you can ask me in the Telegram. I'll upload this file in the Telegram, and then you can start revising again. And my only request is keep your preparation simple. Whatever source you already have is enough. Revise it again and again. Today, my basic thing of teaching you is to tell you that this is how the questions are asked. This is how you have to study pharmacology. Now, any paper, if they set, remember any question paper, if they set 60% of the questions are repeated. 20% of the questions will be moderate. Another 20%, how much ever you study, you won't be able to answer. But my request is those 60% which is repeated should never be made mistake. If I want to take an example of cricket, if you get out for a bouncer or a googly, that's fine. But if you get out for a simple ball, then that is your fault. So that's why stick to the basics. Don't make mistake with already repeated ones. So my best wishes to you all, and please, if you like this, share to your friends also, and like this, subscribe to the channel, and thank you all. Thank you. Anything you want to ask me? There for another 5 minutes. The problem is the time. Okay, to fix this day only I took so much of time because I had to take classes in other places also, so I won't be able to do that. See, suicide inhibitors not required for these things and all. These are all INACET based questions because recently they are asked in INACET suicide inhibitors. In INACET, the level of pharma is second year. So the layer they go in detail, they ask in detail. And nobody had answered this question of suicide inhibitor which was asked in recent INACET. So that doesn't mean that you should go for FOMO that I don't know suicide inhibitors and all. No. Please stick to the basics. Please revise them. That much is enough for you guys. Okay, so any other queries? Another 2-3 minutes are for you. Now my request is again, don't go for any new informations. That is why we made this simplified, which is already known for you. It is a revision session, so it will become easier for you.